Morning, everyone. Thank you for joining us for the Medical Board of California Quarterly Board Meeting, Day 2. While this meeting is being conducted with participating board members and staff at the Sacramento meeting location, this meeting is being streamed interactively using WebEx to allow for remote public comment in the same manner as recent meetings. Public comments for those who wish to speak will be heard for each agenda item for individuals attending in person and remotely. To be ready for remote public comment, we ask that you please ensure your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you are having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. It's my headset. I apologize for the echo. Dealing with the room audio as best as I can here. If you have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to your meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect to your phone to the name you joined the meeting with. By using this method, if you're having audio problems with the device, this will allow you to still participate and hear the audio of the board meeting. Please see the View Additional Information link on the first page of the meeting agenda for more information on connecting to the meeting and accessing meeting materials. Thank you. President Hawkins, you now start the meeting.
Good morning, everyone, and welcome. I want to ask all of us to please turn our mobile devices to silent. You may notice board members accessing their laptops, phones, or other devices during the meeting. They're using their device to access board meeting material that are in electronic format. If you are a member of the meeting and require assistance or information, please see Ali Shembra. Ali, please identify yourself. Thank you. This is an official business meeting of the Medical Board of California, and disruptions of the board's business will not be tolerated. Government Code Section 11126.5 allows a board to remove people who willfully interrupt a meeting and to clear the room if order cannot be restored by removing or muting the disrupted people. The board welcomes public comment on any item on the agenda, and it's the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand or come forward and you will be recognized. This meeting is also being streamed via WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host, who will be facilitating the WebEx meeting. During each agenda item, the host monitoring the WebEx will activate the hand raising and Q&A feature WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call on the individual who indicated they wish to make a public comment by the name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual and will have 3 minutes to make the public comment, but this time period may be reduced depending on the number of people who wish to speak so that more people can be heard. The host will audibly announce when 30 seconds remain to conclude the public comment. After the individual's time for public comment has lapsed, the individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. I want to remind all speakers to please stay on topic and keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law. We plan to end today by 3 p.m. However, I want to remind the members after item number 16, future items on the agenda, we will be going into closed session for item 17 to conduct the annual evaluation of the executive director. I'd like to call the meeting to order. Ms. Struthers, please call the roll.
Dr. Bullock?
Here.
Dr. Dingra?
Yes.
Dr. Helzer?
Here.
Ms. Jong? Ms. Lawson?
Here.
Ms. Luviano? Dr. Mahmood? Dr. Thorpe?
Here.
Dr. Sai?
Here.
Mr. Watkins?
Yes.
Dr. Yip?
Here.
Dr. Hawkins?
Here. Thank you. A quorum is present. I would like to remind the members again that we'll be taking a roll call vote on all action items. Moving to agenda item 11, a presentation of successful elements of a physician health program. Dr. Bundy and Dr. Early. I'm very pleased to introduce our 2 speakers, Dr. Christopher Bundy and Dr. Paul Early. Dr. Bundy is the Executive Medical Director of the Washington Physician Health Program, WPHP, and past President of the Federation of State Physician Health Programs. He's board certified in adult and geriatric psychiatry and addiction medicine, and is clinical associate professor of psychiatry at the University of Washington School of Medicine and Washington State University Elson S. Floyd College of Medicine. Dr. Bundy draws on experience as a healthcare leader, medical educator, and physician in recovery to support education and advocacy efforts related to physician health and well-being. Additional details may be found in Dr. Bundy's bio included in the material. Next, Dr. Early has been an addiction medicine physician. Dr. Early has been an addiction medicine physician for 39 years and specializes in the assessment and treatment of healthcare professionals with substance use disorder. Dr. Early is a distinguished fellow of the American Society of Addiction Medicine, ASAM. He's a past president of ASAM and has been on the ASAM board for over 20 years during his career. He's been the medical director of 2 nationally acclaimed addiction programs specializing in the care of healthcare professionals who suffer from addiction illnesses. Currently, Dr. Early is the medical director of the Georgia Professionals Health Program, Incorporated, which is the physician's health program for the state of Georgia, and a past president of the Federation of State Physician Health Programs. Further information is included in Dr. Early's bio, which is in the material. We're very much pleased, both of you, we very much appreciate both of you joining us today to discuss successful elements of physician health programs. We'll start with Dr. Bundy. And again, welcome to you both.
Myself. Can you all hear me now? And do you have my slides in view?
Yes, Dr. Bundy.
Great. Good morning, everyone. My name is Chris Bundy. I'm the Executive Medical Director of the Washington Physicians Health Program. Thank you, President Hawkins and members of the committee for taking time out of what are no doubt busy schedules to consider some thoughts and ideas around physician health programs. We've been following, as a federation of state physician health programs, the California story, as we refer to it, for many years now. And we are, frankly, breathless and a bit excited to be here with you at this juncture, where we believe California sits at a crossroads. And that crossroads is really whether California will take steps at this juncture to really finally develop a physician health program that meets the best practices and standards of physician health programs as they currently exist in 47 other states in the country. And I'm not just a casual bystander. We're in Washington, pretty close to you guys, and we share a lot of health professionals and providers between our states. So the issues that and the problems that occur as a result of California's lacking a physician health program are felt in a very real way and in a day-to-day way here at the Washington Physicians Health Program. As I mentioned, you are currently one of only 3 states that does not have a PHP, and your current statutes and regulations, including the Uniform Disciplinary Standards, or the uniform standards, as you call them, really make it difficult for you to enable a PHP in California that aligns to best practices as elucidated in the Federation of State Physician Health Program guidelines, as well as our peer program enhancement and effectiveness review standards. Your statutes and regulations don't enable the scope and penetration needed to address what we consider to be existing unmet need in California. 30% of physicians will have an impairing health condition during their career. 1 to 2% are currently impaired. The existing regulations propose a program of no more than 50 participants. That simply would reflect massive unmet need in California compared to what's currently going on in other states. Nature abhors a vacuum. So hospitals and healthcare organizations in California are currently adapting themselves to the fact that California has for many years now lacked an effective physician health program. It's basically a DIY system where hospitals and healthcare organizations are casting about trying to do what physician health programs do, but that is fraught. It's fraught by lack of consistency in application across hospitals and healthcare organizations, lack of expertise in how to do this work well. And it's also fraught because employers really shouldn't be in the PHP business for reasons that we can discuss in more detail if needed. I think that in order to really move forward with clarity, we have to operate on the assumption that doctors and patients are currently being negatively impacted in California as a result of the current state. And it's my understanding that this body is interested in addressing that and recognizes that need. I already mentioned this just a moment ago, but we have to take it as a given that there is impairment currently in the healthcare workforce and that your healthcare workforce is struggling. In the wake of the pandemic, mental health problems have not receded in the physician and healthcare workforce population, they've only increased. So we know that there's unmet need. Now, Washington didn't just decide to flip a switch one day and develop a physician health program. This took years. We started this process inside of our Washington State Medical Association after it's actually the wrong date, 1973, JAMA published the seminal article, Sick Physician, which was a call to action for state medical associations to develop peer assistance programs to help doctors who had mental health or substance use issues or other conditions that could impair safe practice, providing a confidential, therapeutic, safe alternative to discipline so that doctors could get help and support. And that the idea being that if there was a confidential and safe mechanism for doctors to get support, that they would, and they wouldn't, the culture of silence and the doctors that were fearful of seeking help because of fear of professional consequences or disciplinary action would be served. So in Washington in 1974, we created a committee called the Committee on the Personal Problems of Physicians. And that went along, it sort of developed its experience over the ensuing decade. And then in 1987, the Medical Association decided that this really should be spun out as a separate program. It was established as an independent nonprofit with surcharge funding and an independent board. In that iteration, the Washington Monitored Treatment Program. And then in 1993, a physician-led independent nonprofit, a name change to the Washington Physicians Health Program, funded through surcharges in Washington that license holders pay that are eligible for the program when they get or renew a license, but maintaining ties to organized medicine in the state. So the Washington State Medical Association continues to approve our board of directors, approves any changes to our bylaws, and I sit on their board as a liaison. The enabling legislation that would come about to help Washington Physician Health Program become a leader amongst physician health programs, I can't take credit for it. Like many of us, I stand on the shoulders of giants and I tend the garden that they built. One of those giants is Dr. Lynn Hankes. Lynn Hankes came to the program in 1991 and identified key elements and legislative initiatives that could strengthen WPHP and make it a model program amongst physician health programs. Mandatory reporting in Washington. So Washington, unlike California, is a mandated reporting state. All DOH, Department of Health license holders in Washington are obligate reporters of concerns for impairment, and that is the threshold. A reasonable concern for impairment triggers a mandated reporting obligation, impairment being defined as inability to practice with reasonable skill and safety, as it is in most states. Our legislation authorizes our medical board to contract with a physician health program, in this case WPHP. That program has to be approved, however, by the regulator. The DOH supplies the contract, but the regulator is always in charge of approving the program. And it's an important point because trust between the physician health program and the regulator is paramount. We didn't start out with that trust in Washington. That trust took many, many years. And actually, when Dr. Hankus came to Washington from Florida, he identified pretty quickly on that the first order of business was to develop and maintain trust with the medical board in order to do this work well. Our legislation authorizes a surcharge, currently $70 per license holder per year to fund the program. That's 80% of our operating budget. This will be important later as California thinks about how it might fund a program that would need to serve some 750 to 1,500 physicians. Mandatory reports can be made to the physician health program in Washington in lieu of a report to the regulator. People can participate in the program confidentially unless there has been an episode of patient harm related to the referral. Additional enabling legislation, we can receive confidential referrals that are never known to the regulator. And in fact, in Washington, and I will show you some data from some other states, 85 to 90% of our program participants in any given year are never known to our state medical board. That means we're actually penetrating the physician population in Washington very well. And in most states where programs are only utilized by those who are discipline involved, the numbers are much, much lower, but we know that the need is greater. Our PHP must notify the regulator as delineated in statute. And I believe that Ms. Webb has provided you with some examples of our statutes immediately for any physician who poses an imminent risk to patient safety, and in a timely manner for a program participant who fails to cooperate with the program requirements or is probably unable to practice safely. And that's the actual statutory language. PHP records in Washington have special protections. 18-130-175 in your regulations delineates those special protections so that the records of WPHP are immune from discovery and legal proceedings. This is important to reassure individuals that if they participate in the program, they're not going to have their records exposed in legal proceedings that may have nothing to do with their practice of medicine, a child custody case, for example, or other. PHP and those making referral to the PHP have statutory immunity protections. The founders recognized that in order to do this work well and to have true accountability and hold participants accountable in the program, we would need to have immunity protections against civil liability. And actually in the statutes in Washington, the courts are encouraged to impose penalties upon individuals who seek to harm the physician health program or others reporting to it as a result of good faith efforts to protect the public. We want to talk just for a moment about what we call the FSPHP triad of confidentiality. And Washington certainly has good examples of that triad of confidentiality. First of all, we have licensure questions. We actually have an attestation model in Washington where individuals are not asked specifically about health questions. They are asked about current misuse of substance, but they are not asked about prior mental health diagnosis or treatment. And we do have a safe haven provision even within that attestation that acknowledges that if an individual is working with the physician health program and known to WPHP, they don't have to answer health-related questions as a part of licensing. The PHP, as I mentioned, is an exception to mandated reporting. The PHP has a confidential track where participation can be unknown to the regulator. That's the second prong of the triad of confidentiality. And third prong is the records protections that I already mentioned. So this is something that I think is really important for California to be contemplating, especially as it applies to the uniform standards and the ways in which the uniform standards actually would make it impossible to achieve this triad. The statutes are listed here, but I believe that Carrie has also provided those. I wanted to just show you some data from a newer program and a little bit older program. West Virginia is one of the newer physician health programs. And at inception in 2007, the medical board in Virginia had 3 individuals that it was monitoring. The development of a confidential therapeutic program in which people could voluntarily self-refer to the program, hospitals and healthcare organizations, peers and colleagues, treatment providers of those physicians could refer to a program confidentially. The graph really illustrates how many more physicians were able to get help and assistance and chose to get help and assistance voluntarily who are not discipline involved in West Virginia with the development of the West Virginia Physicians Health Program. And this is not an unusual experience. And Dr. Early will talk about the Georgia experience in a couple of minutes. In Mississippi, prior to the PHP, the board was monitoring about 20 to 25 participants with the development of the program of confidentiality with the State Medical Association in Mississippi. Within just 2 to 3 years, they were monitoring 125 to 135, which was a penetration of about 1.75% of physicians believed to be practicing and licensed in Mississippi at the time. And they've consistently monitored that number of participants over the ensuing 20 years. So clearly, the development of the triad of confidentiality, a program of support and treatment, encourages utilization and better penetration of the target population, more help being sought, more safe care being delivered. In WPHP, I just would show you kind of for your own edification where our referrals come from. I mentioned to you that 85 to 90% of our referrals are not known to the licensing board. Last year, about 10% of our referrals did come from the licensing board. There is a conduit for that. They refer to us. We have to report some folks to them. But we also work closely with graduate medical education, professional schools, so the medical schools in which I'm a faculty of refer students to us. So we're really able to help physicians across the career span. It's not an accident that now 27% of our program participants are medical students or trainees. We want to intervene early in the course of a physician's career before professional consequences ensue and before physicians are in independent practice if possible. But employers, self-referrals, and a variety of others account for the majority of our referrals. We use a case management model. Individuals who are referred to the program are assigned to a case manager. Case manager follows the trajectory of that individual through their course in the PHP. The blue bubbles here are the work that we do within the PHP. We take referrals. We figure out what's going on. We do an initial assessment process. For 85% of the folks that are referred to us, there's enough information to warrant having that individual begin to engage. We get a variety of other calls that may or may not be anything, but about 85% in a given year go through our initial assessment process. And either at initial assessment or if we need to refer for an outside evaluation because we can't clear a concern for impairment, about 40% will be resolved at that case at what we call the case in development or pre-monitoring phase. And ultimately, we enroll about 45% of the individuals who are referred to us in ongoing health support and advocacy, AKA what you might call monitoring. Most of our referrals are actually cleared, so we're actually providing a fair amount of service and support upstream of impairment. So issues related to career fatigue and burnout, mental health problems that are illness but not impairment. Paul's going to talk about that in a little bit more detail. But I think it's important to recognize that a modern high-functioning PHP is providing a lot of help and support and assistance. Those numbers that I showed you from Mississippi, West Virginia, and so on, those are the folks that are in ongoing monitoring or cases in development. Those are not individuals that we've helped and sent on their way. But that's an important part of our work, and it's an unsung part of our work, I think. I think it's also important to note that the scope of our services has expanded over the years. Now, more than half of our referrals are for non-substance related concerns, representing significant mental health and non-psychiatric medical need that we're having to address, especially as the physician population is aging. And we're seeing more issues related to aging physician health concerns, neurocognitive issues, and so forth. Last year in Washington, we referred 0.96% of our participants under monitoring met threshold for needing to be notified, forfeiting confidentiality and notified to the board. And it was 2.5% of cases in development. We did a little analysis recently with the Washington Medical Board. Well, what happened to those folks that we referred over to the board in the last 5 years? And I think that the two graphs I'm going to show you kind of illustrate that I think the porridge is just right. You know, in a system that's functioning well, where the board is getting and we ask this question all the time. We meet with our board attorneys and staff members, executive directors on a regular basis, minimally quarterly, but I also attend all the board meetings where I have opportunities to have further discussion and talk about process and those kinds of things. One of the things we're always asking is, are the cases that we're referring, are they the right cases to be referring? Is the threshold too high or too low? Are we getting that just right? Do you think that the individuals that we're notifying you about, these are individuals that you needed to hear about? Or do you feel like in some cases we should have notified you earlier? This is initial action. So what does the board do right when they get the notification from WPHP? In 7 cases, they actually closed them. They said, there's not enough here. Those were cases in development where we felt we had a lower threshold than the board would have had for taking action. So that's good. That tells us that we're sending some cases to the board that the board says, yeah, not enough here to take any action. However, in some cases, some things happen pretty quickly. Summary suspension in 3 of those cases. Notice of intent to examine. So those individuals were probably also in the evaluative phase of their work with WPHP, and the board said, yep, you're going to need to go for that evaluation that WPHP wanted you to do, but we're going to do it now. A STID was offered, so orders were offered, non-disciplinary, but often remanding them back to WPHP to follow direction in most of those cases. A couple of cases not remanded back to WPHP, but put on practice restriction. And in 6 cases, a statement of charges, so formal disciplinary proceedings initiated, but not suspended. And then what were the final outcomes for 31 of those cases, 3 still being open? Well, 14 of them were actually closed. A lot of those were closed due to retirement or the individual exiting practice for some reason. 7 resulted in license suspension, 8 resulted in suspension, 7 surrenders, and 2 practice modifications. So this just gives you a little indication of how closely really we work with the board in having transparency, not necessarily around cases that are confidential to WPHP, but certainly transparency with regard to cases that we're sharing, that are discipline involved and in process in terms of understanding what we do and how we do this, and are we serving each other well. Just some key statistics that I'll go through quickly. I already mentioned the high proportion of individuals in the confidential program. 95% of our program participants report needing and benefiting from the advocacy that we provide. In other words, they come to us, they're in some type of elevated temperature water, and through their involvement with us, through illness stabilization, through ongoing health support and advocacy, we are able to credibly advocate for their safe continuation or return to practice in a way that benefits them professionally. As I mentioned, half of our referrals are resolved without need for monitoring. 1 in 4 participants actually describes the program as life-saving. And that's not hyperbole. I mean, I've sat with these participants and they've told me the stories of sitting in their car in the state park with a loaded gun in their lap, about to kill themselves at the time that they were referred to the PHP, and how the PHP absolutely changed their life and their career trajectories. And so we hear these stories again and again, and we know it's true that we are not only saving careers and saving lives, but protecting the public. Our participants, the benefits of program participation extend beyond the impairing health condition. Our participants report lower levels of burnout. We've been measuring this for over a decade now, and consistently every year, less than half the rate of burnout in program participants is in the general population of physicians. 85% of program participants report their health condition is in full remission at program completion. 84% of current program participants we measure this in an ongoing way. So we always have up-to-date and current numbers that our SUD participants' 60-month abstinence rates are at 84% currently, which is unheard of. In all of addiction medicine, PHPs have reported these numbers, for well over 2 decades now, consistently. Both in large national studies and individual PHP program numbers continue to validate these successful outcomes. And then you think we also are able to get some high ratings of satisfaction from our program participants. So what's in the secret sauce? I talked to you about the enabling legislation. What is that enabling legislation? Adequate funding support? How is it that we're able to get to these outcomes? One is, clinical expertise. Our PHP is staffed by 2 psychiatrists, both addiction boarded, one an expert in women's trauma and recovery. I'm also a geriatric psychiatrist. All of our case managers are licensed at the master's level. We provide high touch service. We have low caseloads, 40 to 50 cases maximum per clinical coordinator on our team. That means we can have a lot of frequent contact with our participants, provide a lot of service and support, and we know what's going on with the people who are in our programs. Over 40 years of doing this work in Washington, we've established stakeholder trust. Hospitals, healthcare organizations, regulators, insurance companies, and contractors all trust the work that we do and trust us when we say that an individual is safe to practice. Know that we'll stop an individual from practicing expeditiously, that nimbleness. So a medical board does a lot to protect patient safety, no doubt. But the need to act quickly to stop an individual from practicing, I would argue that we can do that. And I think our medical board would tell you that we can do that in Washington a lot quicker than a medical board. All I have to do is make a call to an employer, tell them that the individual that I'm working with is unsafe to practice, and almost without question, that employer will take that individual offline until we can establish that they're safe to practice. So having a PHP that can act with that kind of nimbleness and expeditiously to protect patient safety is a strong benefit of having a high functioning PHP in your state. As I've already kind of beat the strong confidentiality horse to death. I've talked about our proven outcomes. There's also a huge education and outreach mission that PHPs engage in, and advocacy. WPHP led licensure reform efforts and is leading credentialing reform efforts in Washington currently underway. We do a lot to support physician suicide. We do a lot in medical education and training. We do a lot in consultation to help our healthcare organizations address workforce sustainability issues, burnout, professional fulfillment, and so on. The list goes on. So again, a high functioning PHP is also not just working with the participants and stabilizing the workforce in that direct way, but also working to promote the profession, to assist the profession in many ways through its stakeholder relationships and education outreach activities. Finally, a good PHP has peer engagement at the level of the Federation of State Physician Health Programs. Paul and I have worked together for years. We call each other on the phone. We share our dilemmas, our problems, our struggles. We share those with others in the Federation. We attend annual meetings. We're on committees. We lead within those organizations so that our programs can be stronger, so that we have immediate access to other leaders in the field who can help us do this work well. My recommendations to you all, if I may be so bold as to make recommendations to this austere body, is that nothing short of a legislative remedy will accomplish what you need in California. And this is true in every state. California is not unique, but you do need a legislative remedy that allows for, that enables the creation of an independent physician health program that is liberated in California from your uniform standards. I actually believe that your uniform standards in California will preclude, in important ways, your ability to have a physician health program that would actually meet criteria for membership in the Federation of State Physician Health Programs. I think that your medical board should retain approval authority for the program. The program should be endorsed and supported by the medical board. You should choose the program, and you should choose wisely a program in your state. And there's certainly many around the country who are ready and willing to help you with those deliberations should you require some help and assistance in how to choose a good program. I believe that you're going to need to have surcharge funding in order to do this well in California. Given the geographic size and the number of licensees that you've got in California, the way to do this wrong and the way for it to fail, and one could argue that the reason that the program fell under scrutiny and had problems back in 2007 and 2008 is it was frankly underfunded for its mission. If you underfund the program, it will do poorly and it will raise the same concerns that were raised back then. And that will be that doctors in the program will not be held accountable. You need to be properly funded to have accountability and to have the kind of support that the public and that you expect. It needs to have the triad of confidentiality, and that needs to be supported in statute. There's AMA model legislation and other examples that can help us get there. And then obviously there needs to be a clear understanding in statute of timely notification of the regulator. I would argue that those thresholds should be at the level of unsafety or failure to adhere to program requirements, similar to what happens in Washington, with some latitude and judgment to a properly funded and expert PHP, giving them judgment and working together transparently around process, even potentially talking about cases confidentially where the individual is known by a number, but you can talk and deliberate about what the medical board would expect in a particular case versus what the PHP is thinking. And developing that collaboration and trust over time can help make it so that you're not in the situation in which California finds itself now, where the uniform standards require the reporting of minor violations, which will essentially thwart any efforts to have a confidential program because the minor violations are so minor. None of those minor violations would get reported to the board in Washington. One of the things that Carrie and I talked about in preparation is, return to use episodes and positive toxicology doesn't get reported in Washington. Our medical board expects WPHP to be the experts to protect patient safety, to address return to use, which is part of the illness within the confines of the program, and to report to them individuals who fail to follow recommendations in the context of a confirmed return to use or are otherwise unsafe. So I think it just gives you a frame of reference or a context in which to understand how this actually is done in other states and how it can be done safely. I think I'm going to not take questions now, even though this slide suggests that I will, and turn the reins over to my colleague, Dr. Early, who I see has been waiting very patiently for me to wrap up. He's got some very interesting perspectives to share with you as well.
Well, thank you very much, Dr. Bundy, for this primer on elements of a successful PHP, and I would look forward to the questions, period. Now we're going to bring Dr. Early. Thank you, Dr. Early.
Oh, thank you for having me here today. Thank you for having me here today. Do I show the slide deck or do you?
Yes, Dr. Lee, you can go ahead and display.
Okay. And I'm assuming that you are seeing my slide deck now. Is that correct?
Yes.
All right. Oh, great. So I think how I want to start this is to be clear about what the medical board and if a enabling legislation occurs and the medical board works towards building a robust physicians health program, how much support you're going to get from people across the country. Dr. Bundy and I, as he said, talk frequently. We work collaboratively. We have standards which have developed over the past 20 years that show what works and how we can continue to simultaneously keep our healthcare force healthy and the public safe. So what I'm going to do is have a little bit shorter talk. Here are the basic concepts I want to discuss with you, and I'll weave this through the discussion. The first is that physicians are human beings, and we develop illnesses just like everyone else. And just like everyone else, sometimes we have a cold or the flu, or we get COVID, or we get stressed or burned out, or we also develop depression, compassion fatigue, and at times have other mental illnesses, which on rare occasions actually do move into impairment. It's important to know that there's a spectrum between developing illness and impairment, and illness does not imply impairment, and I'll talk about that in a minute. Interceding early when a physician develops an illness does prevent impairment, and that's really one of the several ways in which PHPs improve public safety. Because a chief of medical staff gives me a call on a Friday afternoon and says, "Paul, I need to talk to you about one of my physicians," we move that person into, we have them not practice until an evaluation occurs to ensure that they are or are not safe. And then we move them forward through a series of care models that have statistical validity and long-term remission. I'm also going to talk for a bit today about this notion of what safety-sensitive workers are, because physicians are one example of what are known as safety-sensitive workers, and I'll talk more about that in a minute. Dr. Bundy did a fine job of describing how physician health programs really know how to balance the needs of ill physicians with public safety. My job, at the center of my job, is to have a simultaneous attention to the individuals that are referred to us and to have concerns about public safety. And we have ways of balancing that with our medical board, which are facile. And when we act much more rapidly than a medical board can, just because of the way it's structured. We also have extensive research and best practices for physician health programs. They're well known and they're promoted by the Federation of State Physician Health Programs. And this research really shows that physicians who develop some illnesses, notably substance misuse disorders, have exquisite long-term remission rates, unheard of in the general public. So if you have concerns, the general public is always afraid of people that have, alcohol or drug problems affecting others, whether it's by driving their car or exposing others to infectious diseases or whatever. The physicians are a different set, and so you have to think about them as a different set because of the expertise of physician health programs working collaboratively with their medical boards. And lastly, as Dr. Bundy very well articulated, the best way of ensuring public safety, the best way is an independent, state-of-the-art PHP with the evolving trust of the California Medical Board. And I'll show you data in a minute, which I think will help reinforce that. So let's shift to this issue about what types of problems physicians get. Physicians have a problem with work-life balance. Part of that comes from their training and their compassion, their interest in helping people have healthy lives. And some of it comes, frankly, from the changes in healthcare today. Everything from the COVID epidemic to the increasing corporatization of medicine has really dramatically changed work-life balance for physicians. As a result, we have stress, burnout, and what's called compassion fatigue that develops as well. And physician health programs intercede on all of those illnesses. Post-traumatic stress disorder occurs among physicians, especially those physicians with a history of trauma, whether that's physical trauma from being in the armed services or at times childhood or young adult trauma that occurs that causes problems when emotional problems as an adult. Substance use disorders. And finally, for some, and very rarely, but there are maladaptive personality characteristics that expand into workplace conflict, psychological distress, and disease. And physician health programs have a part in managing all of these different types of conditions. It's also really important to remember that mental health issues are interrelated. Someone that has depression will be more likely to be burned out. Someone who has stress will be more likely to have burnout or depression. And someone who has any of these is at more likely risk for developing substance misuse, which needs aggressive care. So these things are interrelated. And by providing not only care for those that get ill, but as Dr. Bundy stated, in our physician health program, we spend, as Dr. Bundy does, we spend an enormous amount of time teaching about physician health, physician stress and burnout, and we start that at our medical school level, and we start that training also in hospital medical staffs and with clinics around our state. Remember that stress begins in medical school, and this data from a Medscape study showed that a large proportion of students sometimes or constantly and frequently feel burned out during medical school. And in addition, there is the stress of debt. The average medical school graduate owes $250,000 in student loan debt by the time they graduate. All of that stress adds to, on top of the work stress that comes from enjoying their practice of medicine, which is a joy for all of us, but does have some unintended consequences through its training and the cost of that training. Some other things to think about, especially when you're considering healthcare professionals with substance use disorders, is that this illness is not one of physicians that are not as good as others. Physicians who develop mental health problems, including substance use disorders, are often the most highly regarded providers. I've spent the majority of my career treating physicians with substance use disorders, the first 30 of my now 40 years of doing this kind of work. And I was always amazed at the physicians who were the chief of staff somewhere, or the chairman of a department, or the head of a practice who develops a substance use disorder, stress, burnout, or other conditions. And this is not something that comes from the the slackers of our physician. Also, once a healthcare professional's illness has been present and ignored, it has the potential, but does not always produce impairment. I'll talk a little bit more about that spectrum in a minute. We all know that mental health problems among physicians intensifies work conflict, deteriorates morale, and risks public safety. And importantly, because of all those things, physicians are categorized as safety-sensitive workers. Well, we talked for a minute about this spectrum, and I think all of us have this vague idea about wellness. Wellness is really as a commitment and repeated actions more than anything else that changes your thoughts and attitudes and behaviors. And it requires concerted effort, especially in a busy physician. If you're a young physician, you've got young children at home, you've got an early marriage, you're trying to figure out your way through a medical staff and find your position at work. You're trying to learn your skill, because physicians are always trying to improve the work that they do. The wellness sometimes takes a back seat, but it's an ongoing commitment. It is a direction and not a finite goal. It varies with the age and life stage, and no one is perfect. What about illness? Well, as we all know, anyone who's a physician, or really the general public, that illness is the presence of disease or symptoms affecting one's health. One is not automatically impaired when ill. And as a matter of fact, we often get referrals of physicians who are ill but do not have current impairment. Those types of referrals are things that, if there is a knee-jerk reaction by legal standards or something like that, it can actually cause deterioration into impairment. Healthcare providers also, through their training and the compulsive nature of their personalities, have a tendency to work while ill. That's considered the norm. Buck up, you've just got a little, you're at the end of your flu, you should be able to return to work, your patients need you. Healthcare workers have difficulties judging when illness bleeds over to impairment, because we tend to see ourselves, by pushing our way through all of our decades of training, we tend to see ourselves as a bit impervious. An impairment occurs only when a disease decreases functionality or interpersonal skills. Healthcare workers live in a culture that works when ill, as I said. The line between illness and impairment can be difficult to ascertain, and this is especially true for mental health conditions. So what we do is overestimate their ability to compensate for illness-related performance difficulties. This is a natural sequelae of learning our skills as physicians and becoming better at what we do. So there's a spectrum, and a physician that has an alcohol use disorder or depression is not necessarily impaired. But the good news is physician health programs can intercede before it gets to the place of impairment, and thus protect public safety. So this is some information from a chapter in the American Society of Addiction Medicine's textbook on understanding how to treat different people with substance use disorders. This is a chapter that I wrote with several other people who work in our field. Now, it's important to know that physicians are not alone in being safety-sensitive workers. Airline pilots, police and firemen, members of the judicial system, power plant operators, including nuclear power plant operators and healthcare workers, are all safety-sensitive workers. And the other piece of the work that I've done through my time, by the way, is with airline pilots. Airline pilots develop alcohol problems just like the general public. And the airline industry, in their wisdom, actually, many years ago, at least partially because of the work of Lynn Hankus, who you heard described by Dr. Bundy earlier, helped the airline pilots and the airline pilot industry develop standards that were taken directly from the physician health program process. So what the process that we have is tested outside of the physician world, and with airline pilots, the success rate is as high as it is with physicians because of the nature of the ongoing monitoring that occurs. The airline pilot industry is safe, physicians are safe. So as I said, we have specific substance use disorder protocols developed by the American Society of Addiction Medicine, another organization that I'm affiliated with, and once we've had science and research-based protocols for treatment and disease management. This isn't something someone cooked up in their basement one day. This has significant research that shows it works. So why is it that physicians don't report their illness? Well, overwhelmingly, one of the reasons is because they themselves don't recognize they're ill. It sometimes defies logic, but I have had the pleasure of working with some of the brightest minds in the medical world and actually in the airline world through most of my career. And it is shocking how hard it is for a physician to recognize that they themselves have a substance-related problem. But even when they do, they have fears about license of licensure, which tends to have them not, when they don't know what to do, when they don't have a physician's health program, they would have a tendency to have those fears decrease the probability that they are going to call attention to themselves. Also, families assume that the one or the only family breadwinner will be pulled offline with resultant financial loss. And the ignorance about substance use and its excellent prognosis in this group of individuals, this cohort, is also relevant. A physician who does recognize they have an alcohol problem comes to me all the time and saying, I know that, my career is over. I'm never going to be able to do this because I don't know how I'm going to have long-term recovery and safety to return to practice. And I say, au contraire, we can offer you an excellent 85, 90% long-term disease remission if you get into this program, which has science behind it. We also, as I've hammered into the ground, have a culture of working when ill, and healthcare systems who don't have an easy conduit to care, such as a state physician health program, don't know what to do. Today in Georgia, we're a relatively young program, and I'm going to talk about that in a minute. Today in Georgia, all of the chief medical officers of every major hospital or hospital system in the state have my phone number on rapid dial. And they know when they have any kind of concern, or even if they're a little worried about someone, they can call me up 24/7 and say, I'm worried about Dr. X. And we talk with them, and through that discussion, a referral often occurs if necessary. So why is this whole treatment process so good? Why does it work? Well, basically, if you have a substance use disorder in the general public, you go to some kind of care model or you get a medication, and your treatment lasts, maybe it's an outpatient stay, maybe it's even a residential stay for a period of weeks, and then that's it. And physicians instead have long-term disease monitoring. And why in our case, it's 5 years. Why is it 5 years? Well, there are multiple reasons, but one of the strongest reasons is because that is the standard by which the cancer industry and the cancer treatment industry evolved. So physicians go to some initial dose of treatment. It is often weeks long. They are removed from practice in the vast majority of cases, so that the public can definitely remain safe. They often do that in a residential setting, which lasts anywhere from usually 60 to 90 days. And then for the entire 5 years subsequent to that, they're subject to substance screening. The thing that's so great as a disease, if you have to have one mental health condition, substance use disorder is sometimes the best, because we have a definitive tool that can determine the status of that illness through very sophisticated substance screening. All of our participants also engage in some type of mutual help meeting. That sometimes is things like Alcoholics Anonymous or Narcotics Anonymous. Sometimes it's through their church or their synagogue. Sometimes it's through a Buddhist type of support network, but there's types of mutual help meetings which help people not only develop remission, but learn healthy life attitudes so they can stay healthy. We place these people in these support groups. My group of people, I meet with them once a week for 5 years while they were with us in our program. And they meet with us so that they can talk about how they can continue this journey of healthy recovery. We also engage them in group therapy. Some need family therapy, sometimes need individual therapy long after that initial dose of treatment. This is a chronic disease management system for a chronic disease, whether it's depression or substance use disorders. And that's one of the reasons why, and probably the strongest reason why this model is so effective at long-term remission and thus public safety. Real quickly, some studies. These are older studies. They're in the process of being repeated now. These blueprint studies reviewed 16 physician health programs, 904 consecutive physicians with substance use disorders. 78% had successful completed without a single detected return to use, including those with relapse who then had further interventions. Over 90% of these individuals are doing well at 7.2 years. That shows that the remission rate is very, very high. If this was cancer, we would be talking about cure. But because it's substance use disorder and because of public safety, we don't use that term. There was in those studies of those 904, there was a single report of patient harm where a physician overprescribed to a patient. That was the extent of the damage caused by people within this system. Now you compare that to individuals in the general population, where some were probably the best studies indicate that it's 35% or less of individuals remain abstinent 1 year or more. With that kind of difference, what we're talking about is a different disease model which ensures public safety and health of our physicians. So PHPs help ensure that everyone is better off. Ill physicians get care earlier, reducing the burden of impairment. And when you have a PHP, the safety of physicians in your state improves dramatically. The public is protected, even in the small number of cases who do not cooperate with the PHP. I'll talk about that in a minute. The state does not lose well-trained physicians, which are in increasingly short supply. I mean, I'm at that age where now I have to see physicians a lot more often, and it's hard to get appointments because our healthcare burden in Georgia is our healthcare system is deeply burdened, and I'm sure it's that way in California as well. As well, licensure boards improve their protection of the public, and that's how PHPs work synergistically with PHPs to ensure the health of all Californians. Now I'm going to spend the last couple minutes talking about an example distribution, and this is an example. You know, I don't want to say these numbers mean anything at all, but let's just say that 0.5% of physicians get involved in your PHP. And this is a small number. Most states show that number is higher than that, as long as the PHP is well designed. And you heard Dr. Bundy's numbers were much higher than that. But let's just go real conservatively and say that 0.5% of California physicians get involved with the PHP. what happens if the model is somewhat like Georgia's model, or like the model of other states, like Washington State. The vast majority of those people would be held within the confines of the PHP. And by held within the confines, that means the PHP keeps those people in a relationship with the PHP where they are accountable, but the licensure board has no action or doesn't know about those individuals. Now, when that group of individuals, if something happens with those individuals, then the PHP takes action. We don't, if someone's with us, we don't we say to all of our participants when they join with us that we cannot guarantee that at some point we will not be discussing your case with the board, or that we might turn you over to the board depending on your situation. So there is no guarantee of that. Then you see 40 other cases that are what we would call that are somewhere that are in the PHP, but because of concerns around public safety, an event that brought them in, the fact that they came through a licensure board at first, they actually are in the PHP, but known to the licensure board. And I'll describe how we work with that in a minute. Then there may be some cases that are solely covered by your medical board. And that's the case, at least now in Georgia. We have a very small percentage of our people who say, we don't want to be in the PHP, we want to be with the medical board. We say, fine, that's okay. The licensure board then monitors those individuals as they've done in the past. And a very small percentage of those people might need license sanction of some type. Now, let me describe to you for a second what happens with individuals in our program. When people come in, as I said, we do not guarantee that they're going to remain unknown to the medical board. It might be that they had, for instance, a DUI, and then the local policing authority reports that information to the medical board. When we first started out, our medical board would say to us, they've had a DUI, so we need to stay on top of them with you, Dr. Early. And what we meet with our medical board on a monthly or more often basis if necessary, and we discuss cases that are known to them. We also early on discussed cases that we had concerns that the medical board might need to know about them without revealing names at first. And after discussing the case with our wellness committee, the wellness committee would say, no, we don't need to know about that case, but next month or earlier, if anything happens, you tell us about it. So there's a collegial way where the licensure board understands its mandate is different than the PHP. And the PHP understands that if the licensure board does not trust what we're doing, all is lost. So we're a younger program, unlike the Washington state PHP. We're a younger program, and we are constantly discussing our cases confidentially and some non-confidentially with our licensure board so they can build trust in what we do. And that trust has been building over the years until now. Almost all the time, our licensure committee, the wellness committee that talks to us, says, when I talk about a case without revealing a name, they say, if things get worse, you talk to us, otherwise hang on to that case. So this trust is built over time by this relationship with the licensure board, which is so important. So we have 520 under confidential monitoring. We have 40 that are followed by the PHP and known by the board. And then you see that 20 and 8 that are outside of the purview of the PHP itself. And that's all I have. I'm certainly ready to welcome any kind of questions. And I'm sure Dr. Bundy would be happy to answer with you as well.
Well, thank you both very, very much for this comprehensive, albeit primer, on approaches. This presentation will help our medical board consider next steps. I'm reassured that there's a science around these chronic illnesses that has the potential to result in impairment and potentially harm. And the model, it's exciting that PHPs that are best practices are more efficient than medical boards. And particularly pleased and excited about the desire to be of service in medical boards who are trying to figure out how to do this. We appreciate the invitation, and I believe as we explore our journey, we'll be reaching out to you. Questions from the members? Dr. Hauser?
Thank you. Thank you to Dr. Bundy and Dr. Early for your excellent informative presentations. My question is for Dr. Bundy. You had mentioned in your presentation that a mandatory report can be made to the PHP in lieu of the board unless there is patient harm. And I'm curious, I can envision circumstances in which a physician comes to the attention of a practice or medical staff leadership following a near miss or an adverse event that requires treatment that's not anticipated, or perhaps a prolonged hospital stay, but from which the patient recovers. Would such an event be required to be reported to the board, or would that remain confidential and be within the PHP?
Hi, Dr. Hauser. Thank you. I don't know why I'm echoing. But that's an excellent question. Actually, if you ask them, I would sort of put it to you. How does your medical board define patient harm? Because if I'm in doubt as to, so when I get a report, and if there are clear cases in my mind of patient harm. There are clear cases where there has been no patient harm. And then there's a lot of gray areas, what might constitute patient harm. I would rather ask for permission rather than forgiveness on the issue of patient harm. So one of the things I'm going to do is, if the hospital's calling me, I'm going to ask them, do you have a mandated report based on this event, this near miss, this adverse event? You talk to your risk management people, you look at the statutes with regard to what it says about reporting patient harm and how you discharge your responsibility. And you have to make a decision as to whether patient harm has occurred and whether you have to call the medical board. Now, I'm going to make an independent decision about what I think, and that's going to probably be based on me presenting the case in an anonymized way to the medical board and asking the question, does this in your mind constitute patient harm in such a way as to preclude this individual from being able to be a confidential participant in my program? Is this something that you think needs to be reported to you? So when I'm in doubt, I'm going to actually ask the regulator what their position is on it. And I'm going to probably without question, I'm going to defer to the medical board on the issue of whether they think that the event or the issue has constituted patient harm. It's actually, I've asked a lot of attorneys, and I've done a lot of, if you could ask ChatGPT-4 what constitutes patient harm, and it's interesting the variety of responses that you get in terms of where that threshold is.
And if I could jump in there, that's exactly what we do, and that's what I was talking about with those 40 people. That if we get a case that's referred to us and we're not sure, we will talk to our medical board, because the medical board, and we'll say, this is an anonymous case right now, but we have concerns. If it's in that gray area, we will tell them we have some concerns about this case. Do we need to reveal this case to you, or do we need to have the hospital report this case to you? So the medical board has the safety, their raison d'etre is the safety. And so we have to acknowledge that safety item, but there are lots of gray areas, as your question alludes to. And the best way of handling that is from the PHP side, is by anonymously discussing that case with the medical board. And we can do that very rapidly. And the medical board members can say, I think this case isn't that. And so there are ways of doing that. We talk to the board attorneys, that's discussed at the board level. And so because of this gray area in terms of harm that might be something like, as you were alluding to, a patient that had to spend an extra day in the hospital as a post-op complication or something like that. But by having that, trust is built, and the trust is critical between that the board trusts the PHP is critical for the longevity of that PHP, and all of us in PHPs recognize that.
Thank you both.
Ms. Lawson?
Thank you, Dr. Hawkins, and thanks to the doctors for this presentation. I'm grateful to have you here with us today. I had the opportunity a year or so ago to hear a similar presentation at an FSMB meeting, and it's, California is usually a leader in so many respects, and in this case, it's I guess disappointing to me that we're so far behind. My question is the following. California is blessed with a strong patient advocacy community that we appreciate hearing from, that I've appreciated the opportunity to collaborate with and work closely with over the years. And many of those patient advocates have either suffered themselves or have a family member who has been harmed by a substance abusing physician or somebody that's impaired. And so consequently, many of them are deeply concerned about what this type of program means for patient and consumer safety and for safety of the healthcare delivery system as a whole, right? It's in part why we've been in this situation where we don't have a physician health program. So I'm just curious from your both of your perspectives in your states and both across the country, how, can you speak to how you've built trust with the patient advocacy community, other stakeholder organizations, so that you build a system that has that inherent trust, not just to the medical board, right? Because you've spoken a little bit to that relationship between the medical board as the regulator and the physician health program, but how about the relationship and the trust building that's necessary with other stakeholder organizations?
You want me to start, Chris?
Sure, yeah.
Okay. So I think that the well-meaning folks say, gee, if the kind of approach is if a physician has a substance use disorder, let's just use substance use disorder right now, and has the potential to harm someone, if we somehow create this this public visage that can look at every physician that has a substance use disorder, then we can be more safe. And that's the, as I see it, that is the general sense from the physician, from the advocates that you've talked about. Unfortunately, the exact opposite is the case, because by having a system which gets people into care faster, B, gets people, and people here we're talking about are physicians, gets physicians into monitoring faster, C, has a system that does not have a perceived, only a perceived punitive quality to it, but a rehabilitative quality to it when able, means that more and more physicians, today in Georgia, we get people who call us up and say, I think I have an alcohol problem. I would be willing to bet that no one calls the medical board in California saying, I have an alcohol problem, just out of the blue. So I get people calling me up saying, I have an alcohol problem. What should I do? I'm a physician. I need to get help, I think. Tell me what I should do. So by getting more people into the system, you decrease the risk to the public at large. And it's well-meaning, but it has the exact opposite effect. It means that physicians are going to hide out because they don't understand that physicians who have an alcohol or drug problem don't understand this wonderful program exists where we can have a 90% 5-year remission rate. I mean, if you did that with cancer, everyone would be flocking at our doors, right? But because they don't know of this program and they only see the negative, pejorative, and practice restricting elements of it, it doesn't, it's harder and harder for them to self-report. And then the illness they get more ill with the substance use disorder. They report later on, they have a higher probability of impairment. What is well intended has the exact opposite effect.
Yeah, I would just add a couple of things, going back to the program question, as well as thinking about this one. I mean, I could count on probably one hand in 10 years of doing this work that I've actually had a call where there was a concern of a physician where it was like there was patient harm involved in the referral. I think it's worth stating that is an exceedingly rare event in our experience. And the other thing I would say is patient safety events are happening all the time. You know, I mean, this is not something that's happening just with individuals who have mental health and substance problems. These are, you know, we understand medical error in medicine and the drivers of that. And so I think survivor-based advocacy, which is often what you're hearing in the public interest space, people who have been harmed in the system, those are tragic stories. Those are real stories. Those are lived experience. That is absolutely real pain that exists in our system. And my message is, we're not in the business of hiding out doctors who are there to hurt patients. That's not what we're doing. That's not what we're about. That does not excite me. I can't get out of bed for that mission. This work is hard, actually. I mean, it's the hardest job I've ever had. And I've had some hard jobs. Before I did this, I was the chief of mental health at VA Puget Sound Healthcare System. I ran mental health for veterans on half of Washington State. This is harder. And and I say that because I mean, I think it's really important for people to know that these are good doctors who have bad illnesses. These are not bad doctors. And if they're and it is an occupational hazard of what we do, that from time to time we're going to run into a doctor who has hurt a patient or who needs to be disciplined. And it is not our role to shield or mitigate individuals who need to go through a disciplinary process, rightfully so, from doing that. We can, and two things can be true at the same time. Somebody can need discipline and somebody can have a substance use problem. We can help them with their health issue. Whether or not they can even stay in medicine is another issue altogether. Sometimes we do have to help people who can no longer practice find something else to do. Again, those are extraordinarily rare cases, but I think that the goal is to always engage and validate somebody's experience while also saying that experience can only inform the solution to a certain point, but that we know that the solution has to be more nuanced and complex than just focusing on individual bad doctors. Sure, that survivor-based advocacy tends to focus almost exclusively on that as being the solution, versus looking at the larger picture, which is how do we actually get the most care to the most doctors in a preventive fashion to avoid things getting to that point in the first place. And so the further that we can be upstream of impairment, and I mentioned medical school, residency, I mentioned, you know, the confidential triad, creating this protective bubble in which people feel safe to come forward before something adverse has happened. My experience is that the low numbers of adverse events that we're seeing in program participants or on referral, and the increasing numbers that we see with that confidential conduit, it gives us pretty good data to support the idea that idea of earlier intervention through a confidential therapeutic strategy is actually working. The more we can decrease disease burden of impairing health problems in the entire population of physicians that are potentially affected, the better off the public is going to be from a safety standpoint always.
Well, thank you for that response, and thanks for reminding us that these are physicians with an illness, a condition. Some are severe, some are not so severe. Some are not adequately diagnosed yet. But the PHP is not a shield for doctors. That's not your goal. Your goal is to help the physician through this journey that they're in so that they can continue to provide service at a high level or an appropriate level, a safe level, if it's appropriate for them to continue, and to protect the public. Dr. Thorpe?
Thank you, Mr. President. And thank you both excellent presentations and very very sobering, actually, as I share Ms. Lawson's concern that in California we typically think of ourselves as leaders in healthcare. Maybe we're leading down, maybe we're leading up, but we have a tendency to be the leader in many ways. But in this case, we are not. And I think, you know, one of the statements that you said, Dr. Bundy, is that the uniform standards is a significant obstacle to developing a physician health program, and that, I think, is really a difficult obstacle for us to overcome because of the concerns Ms. Lawson mentioned with our, you know, the adverse outcomes of our survivors of tragic outcomes in healthcare. And it's a powerful legislative tool. It's a powerful, it is not something we can ignore and certainly have no wish to ignore. It is something that we need as a medical board. If we are going to have an effective program, we need to have buy-in from our patient safety advocates, as well as it's not just a partnership with the physician health program and the medical board. I mean, that trust needs to be developed, but I'm looking at the West Virginia experience, and I see, you know, there were 3 people in 2007, and today there's 315. Well, that's 17 years. That didn't happen overnight. You know, even to get over 200, it took 10 years. So there's a significant process that we need to go through to be able to develop trust, with the public. We need to develop trust with our licensees. The trust needs to be developed between the medical board and the physician health program. And I guess my question is, where do we start? It just seems overwhelming.
You want to go, Paul, or do you want me to go?
So, yeah, I have a couple of quick things. Well, I'm echoing now. So real briefly, you already have some expertise in your state. C3PH is an organization which is dedicated to physician health. You've got some people at all of your major universities that are active in physician health. You have to have expertise there. I can certainly say from other states around the country, including Georgia and Washington State, if you need us there, we will come to help how we need to do that. And so I think that the issue is you have expertise in your state. So talking to C3PH would be really one of your next steps. Getting someone to attend designate a physician who can start becoming part of the Federation of State Physician Health Programs as you're beginning to build this. But you're right, the uniform standards, when we reviewed them, is a heavy lift and is aimed to, unfortunately, to directly thwart the development of a program which is going to have the best impact on public safety. Well-meaning, but the outcome is the exact opposite. So I think working with legislators, and again, if you need us to work with legislators, the cool thing about this is we don't have any competition in the PHP world. I call up Chris, he says, oh, I did this. This is how we did it. And we share secrets so that we share what we've learned. And we're here to share that with you as well. Because frankly, when we get, we tell physicians that California is a difficult state for your license right now. If they have licenses in multiple states. And we want you to be part of this process, which has science-based assistance in improving public safety. And so I think starting with the people that know in your state and the people around you is certainly one way. And then the other piece is that legislative heavy lift, I think.
Yeah, I would say that you want to get your hospital association involved. You want to get your medical association involved. I mean, I'm not a lobbyist and I'm not an expert in legislative process, but we have run some bills here in Washington. I have some familiarity, and I think that's, it is going to be a heavy legislative lift, and you're going to have to be working all those angles as you go to the legislature and think about crafting and drafting that legislation that includes, an exception, frankly, for the program. I mean, one of the ways that you might craft the exception is because you have a program that you would allow. Sorry, I don't know where that was coming from. That sounds like it fixed it. Maybe it just muted me, and that solved it.
It's our end. Sorry.
It's still happening. So the reason I say all this is because I do think it's going to be a process, but I think some good legal minds could sort of help you as well. In other words, an independent program, a 501c3 independent nonprofit that stood up, for example, to run a program, as was done in Washington, for example, that program would not necessarily have any obligation to conform to the uniform disciplinary standards. The problem that you have is that you're trying to run a board program that's subject to the uniform standards, but a non-board program, a board authorized program, but not a board program, could potentially be a loophole through which the uniform standards would simply not apply. But that's I think that where there's a will, there's a way. But that's where I'd start, is by getting the big stake. Your hospitals and healthcare organizations are really going to benefit from the PHP. They're going to be the ones that are going to see the value add, because they're going to want a solution. They've got docs in their systems right now that they don't know what to do with. They're standing up these health and wellness committees, and I can tell you from experience of how those doctors have been handled in those programs and then landed at my ranch, that often has not gone well. And I suspect that based on the feedback that I get from the CMOs and CEOs in Washington about how much they depend on WPHP to handle those difficult situations that arise on a 4:30 on a Friday afternoon with a doc who's in some kind of trouble, those are the folks in your state that are really probably going to rally behind this and want that service and that support going to be available to them. So I think just finding where the value proposition is for the different groups, and then really engaging with the consumer groups to understand that these programs should be stood up with some good accountability measures in place too. I mean, it's not, consumer advocacy groups often confuse confidentiality and transparency. I'm a very transparent program. I report all kinds of data about our outcomes, suicides in the program, lots of data to try to give an x-ray into what we're doing. I feel like the PHP in Washington operates under a microscope of scrutiny, and that's as it should be. That doesn't mean that you know the identity and the protected health information of our participants. I can provide a lot of information about our effectiveness and our safety without divulging the personal protected health information of individuals in the program. So I think providing some reassurance to those groups that this program will operate with transparency and with accountability, and there will be a process to evaluate that. Even the Federation's audit program, the way that you have it regulated currently, it would be audited every 3 years. Federation actually provides a system to provide that auditing to make sure that the program is complying with best standards. So saying let's do this and let's see how it goes and let's measure it and let's maintain that accountability, and what would that look like, might go a long way towards reassuring folks that are really on the consumer and public interest side that there's an intention to be transparent and to run this program as well as it can be run to protect patient safety. Let's learn that together.
Dr. Dinger, followed by Mr. Watkins.
Thank you, Dr. Bundy and Dr. Early, for your very nice presentation. And I just have one comment and one question which I will pose. But I think we have certainly recognized there's a gaps in the physician well-being in California, in general, for the whole country. And most of these things, I think we need to address, we try to address at the local level as a hospital physician well-being committees. and through the chief of staff and those offices. And I definitely recognize your comment that it is difficult to deal sometimes. But the most of the times, what I think, if we can integrate all these information from all the hospitals and all the related medical societies and the local medical societies and California Medical Association for that matter, I think we'll be able to start somewhere to answer Dr. Thorpe's question, that we have some resources. It's not like we are totally lacking the resources. And then I have used many times the PACE program in University of San Diego, which has really helped us in many times and took us out of the loop where we had a very difficult time in addressing especially the substance abuse and those kind of issues. And the other part which also I feel is if we can combine these resources in California and request the medical board and legislation and at some point California Medical Association and Hospital Association, I think we can come up with a collaborative force to start at that point. And the number two question which I have is what is the financial implication to the affected physician in 5-year program? Because in the first, I think in 60 to 90 days, he's totally off the practice, and there's no financial resource. Who pays for that, number one? And number two, ongoing, what is the financial liability of the physician and physician family towards that program? Does it be reported to his insurance is covering it, or he's covering it personally, or does he have to report these issues to the applications, if applying applications in some other hospital? So what are the implications to that physician well-being during those 5 years? Seems to be a very long time financially if it is not very cumbersome, but we need to know the numbers to make it financially viable program for these people too, because that will affect, may not be the mental health, but it may affect the financial health of their families. So.
Why don't you start with that, Chris?
Well, I absolutely appreciate the financial burden issue. It's probably one of the biggest barriers, frankly, to PHP participation nationally. We co-authored a paper with A.V. Vincent at Harvard last year looking at financial barriers to participation, obviously more burdensome earlier career students, residents, and then and so on. This is a top of mind advocacy issue for the Federation of State Physician Health Programs, and we are actively looking at ways. In Washington, I'm actually working collaboratively with stakeholders. I believe that the healthcare system that benefits from the work that we do should shoulder the burden of cost, and that we need to figure this out, because historically the brunt of the burden for treatment that's unreimbursed by insurance falls to the individual to cover. 60 to 90 days of residential substance use disorder treatment at a center that specializes in the care of physicians and other safety sensitive workers is often not covered by insurance and can result in substantial out-of-pocket expenses, not to mention the monitoring program expenses. I would say that there's what we can control and what we can't control. I think you have to take your advocacy issues in step. I would say getting your program in place with a subsidy from a surcharge is part one. The cost burden to participants in the current program that the California Professional Wellness and Health Program that you're currently looking at, the cost burden would be, I think some people would actually leave the field rather than absorb the cost that your current program is requiring. Program fees currently for participants in Washington are, for a substance use disorder monitoring program, $200 program fees a month plus toxicology testing. It's not insignificant, but it's manageable. It's maybe $500 a month. That's subsidized. You go to a state where there are not those surcharges, in order for the PHP to be solvent, those monthly fees are going to be much higher, probably on the order of $1,000 to $1,500 per participant. So by going after the surcharge, you really will mitigate cost to participants. That's one of the other reasons to do it. Then we need to be taking on the issue of out-of-pocket healthcare expenses. The kinds of treatment that we ask for, we get blamed for it. The PHPs get blamed for, sending people to fancy evaluations and out-of-state doctor care. That is what is required for us to be able to actually credibly advocate that somebody is safe to return to work. I'm in the Department of Psychiatry at the University of Washington. I've been there for 25 years. My department can't do this work. The reports that we get that deal with the job-specific work demands of the physician vis-a-vis impairment, potential need for accommodation, all of those issues, fitness to practice, those are 20-page exhaustive reports and discharge summaries. They are rich in data and rich in information, rich in aftercare planning that you just can't get anywhere else, unfortunately. I mean, it should be the standard everywhere in the world, but it's not. But all that said is that comes at a cost. And actually, it's a bargain. When you look at what treatment centers are actually charging for what people are getting, nobody's getting rich doing this work. But that doesn't mitigate against the physician who is out of work. If you're in the airline industry, and Paul can speak to this better than I can, you go out of work for a substance-related condition, you might be out of the cockpit for 6 to 12 months, during which time your airline is paying your salary, your healthcare needs are being covered. The cost burdens are not levied on the individual who's suffering. And we need to figure out a way to emulate that in healthcare.
So I'll piggyback on that too.
And just, sorry.
Sorry. So we always like to look at the airline industry because the major carriers across the United States are willing to pay salaries. They're willing to pay for treatment of their pilots, and they're willing to pay for 6 to 12 months of kind of holding tank time. And the reason they do this is they don't even know that 6 months is necessary, but they're trying to be safe. And the pilots go through very thorough evaluations at the end. And all of that is paid for by the industry because the industry recognizes the benefits of having senior, qualified, bright pilots flying their planes. And yet we can't do this in the medical industry, which is a tragedy. In our state, we're very different than Washington. We don't have a surcharge. We found out, and if there's one thing that is do as I say, not as I do, is don't do what Georgia is doing, because now we have physicians that have to pay for 60 to 90 days of residential treatment, and then the monitoring fees, which are significant, and then the drug screening fees if they have a substance use disorder. And yes, is that a burden? Absolutely. Most of our participants, when they get to the end, they say the cost was a lot, but I'm so much healthier than I used to be that I am actually functioning at a higher level, and they usually can make it up. I will tell you that with the medical students, what happens is we've even had some of our medical schools find money to pay for their medical students to get the care because they have found that it returns healthy students to them. It's less disruptive to the school, and they're in general benevolent organizations. Some of them are very benevolent organizations to begin with. So the system for physicians, you're right, is not good. But the surcharge on the license is the best way to go. And if you want to ask someone how not to do it, financially, you can talk to us. But yet somehow our physicians do that. We have a lower rate for medical students. We have a lower rate for residents, and the rate goes up when you're in practice for your coverage of what we do, because our case managers are in contact with our participants all the time, and that is costly. So having those things there is a good idea.
So Dr. Degan, you raise your hand again, and I'm not sure if they heard the question about how the physician who's in a program should report it to their hospital administration when they fill out their applications.
Oh, thank you for that. I'll just jump on because I've got my microphone on. Usually what happens, most of the time, the wellness committee in our hospital systems know about the participants. We tell people that they can be anonymous to the medical board, but they have to tell the wellness committees. And as our our relationship with the medical boards, the medical board asked us, a very reasonable ask, that there's someone at the workplace who knows about that individual's past concerns. And that individual knows about about our participant in our program and sends a quarterly report that says everything's going fine. And they have our number on speed dial as well. If they're concerned about a physician that's in our program, we respond that day. And sometimes it's with pulling them out of practice. Sometimes it's just saying, are you okay? Sometimes it's getting another drug screen, but we respond rapidly to that. So the wellness committees of hospitals have to know about our individuals, and our wellness committees know us and trust us because they've got, some of our hospital systems have, 30 and 40 physicians in their system that are in the PHP, and they're all doing well, and they welcome them back because in general, our physicians do very, very well.
Mr. Watkins.
Thank you, Dr. Bundy and Dr. Early. I have two questions and a suggestion, solution suggestion. And the first thing is that I want to say, I'm so grateful for your input into this issue that honestly, I have sat on these panels and it has been the most frustrating experience to address any of these substance issues. And sometimes we are at the deadlock because we want to enforce these uniform standards. And the truth is it's not working. And I know this is going to sound controversial, but it's not working. We're not getting the patients a better safety result because there's an escape even in the uniform standards as we apply it, and for various other reasons that I don't even want to get into. But the frustration we feel. And you just presented us with a new way to look at this situation. And it is bigger than substance use. And that is what I think will be missed when, Dr. Bundy, when you said, oh, the uniform standards, we gotta let it go. It sends shivers down my spine at first, hitting every trauma story I've heard from patient advocates, but only because I've been hurt. If I expand my view, more panoramic, and I say, okay, everybody's suffering right now. The patients are suffering, the doctors are suffering, and we need a solution. And up to now, the board and the patient advocates and the associations, we've had an adversarial relationship here in California. I shouldn't speak because I've been adversarial too. So this on a lighter note. And that was based because we don't trust each other. There hasn't always been good faith on both ends of the table. And I'm hoping by being honest today from my end is just to start cultivating a new way. I am committed to a new way. And a new way of looking at this is what Dr. Bundy presented. He presented this, there's a loophole. While we're building trust, because we need to talk to the patient advocates, they've given in these interest party meetings so much input, and they will feel largely ignored because all of their input has to do with the uniform standards, because they're terrified if that goes, everything's going to go. And what you are presenting is an opportunity for all of us. And I would not say this if I didn't feel this. Everybody knows me. This is the board that I feel could actually do this. If I said that 2 years ago, everybody would have laughed, right? But it's the truth. I really feel like I felt the members' commitment to want to have this be different. So here's a solution based on what Dr. Bundy, and I'm just curious to see your input. Right now, we have to build these relationships with the patient advocates. So they're not going to let us, and they're listening, just let the uniform standards go. It's like a safety net, a mental safety net. And so we have to establish authority here with the board to actually implement, to give a PHP, third party, or independent PHP the authority to start doing this in California, right? And I think that's what Dr. Bundy said, as a loophole. Now I'm going to push it even further, as usual. And the board is not going to be able to pay for this. We just went through hell trying to get a fee increase. I've got a proposal here. Our friends from the California Medical Association is here. And I've never really engaged them, but they have been probably the strongest organization that fight for doctor protection, doctor interest in the country. And so I'm suggesting that if the board grants such authority to an independent PHP, that if they would, in the initial stages, while we try to get more funding, provide some of that funding just to get this program, almost like a pilot program, up and running, so that we can see those numbers that we've seen here other states are getting. I genuinely want to see those numbers, because I know everybody's struggling with mental health and just life in general. After COVID, things have definitely, it was bad before COVID. It's almost impossible now for people. And for doctors, when I talk to my doctor friends and my own doctor, it's the same. Overworked, burnt out, end of my rope, I got to go see, I just got to run TJ, I got to do this. So I'm just curious as to if you could give us specific guidance to this board about how we can do the first step, establish that independent PHP that the board authorizes. And then we will talk about funding in, with the patient advocates and CMA and all the other organizations. If we really want to solve this, it's going to take everybody. And I'm willing to sit down, I'm willing to work my butt off for this thing, because a good doctor produces a good outcome for the patients. And there's just too much pain going around. I've seen it, and I'm seeing it from the doctor's end as well.
Thank you, TJ.
I think I appreciate you sharing how difficult it can be to sort of think outside of current circumstances, and how the prospect of rule breaking. IHI, Institute for Healthcare Improvement, they're all about quality. They have a whole organizational improvement strategy around institutional rule breaking. The idea being is that sometimes we need to break rules that aren't working in order to get to a better place. I can't pretend as an outsider to California to understand how to tell you to do this. What I can do is say that what you can do immediately is, one, do nothing. One of the sayings that we have is don't just do something, sit there. It's been a while. You haven't had a PHP for a while. I think the wrong thing to do would be to use your passion and motivation, which I think is very well placed. And I'm glad that we've been able to inspire you a little bit around this. But I think, what you want to do is do the work of having the conversations, having the dialogue, talking to those big stakeholders like, California Medical Association, Hospital Association, others. You could spend 15 minutes just brainstorming a list of stakeholders that you need to be engaging with, including your patient advocacy groups, to sort of talk about why the uniform standards won't work, why they're well-intentioned, but at the end of the day, going to be ineffective in getting the kind of program that's necessary, because nobody will use it. And I think if you looked across your programs that are currently subject to the uniform standards and you looked at the penetration of those programs into your professional populations, you're going to make a case in about 7 minutes that the uniform standards are preventing utilization of those programs. And so, it's really like, can we come to an agreement about what other standards, what would satisfy? Because, there's fear here. Fear is real. There's fear. And when fear drives, we don't get to good solutions. So we have to let people know that we hear their pain and we hear their fear, and we think that there might be a better way to do this. That addresses the fear, that addresses the safety concerns, but does this in a better way. And by the way, I think we need to get rid of false dichotomies. The idea that organized medicine or that the California Medical Association is somehow opposed to patient advocacy. As a profession, we're dead in the water if we lose the trust of our patients. We are absolutely committed to patient safety, patient advocacy, and patient concern. The patient sits at the center of our profession. And let's not lose sight of that. And let's not let others tell us that we don't properly care for or are concerned about the needs of the patient, or that our profession is somehow misaligned to what's in the interest of the patient. I'm also a patient. I also have to get care in the systems in which I operate, in the systems in which I'm trying to support with the work that I do. So we all have a vested interest in the safety of the care that we receive. And we don't need to be forced into, arguments or positions that say otherwise. So I think that there's room at the table for everyone. There's room in the tent for everyone. And that the way that you get this done is through that engagement and dialogue, and giving everybody a voice and a place in the process, but the understanding that at some point we're going to have to come to consensus and get this done. And you have to test the waters for who's got the resources, the ability, and the willingness to start somewhere. And what does that look like? Like in Washington, it started out small. Understand that this may take, to gentleman's comments earlier, this is not going to happen overnight, even with the best intentions and the most passion. But it does need to start somewhere. And I think it starts with engagement. And I think you have willing partners in the state. My suspicion is, based on some of the work that we've been doing there for years, and you have partnerships nationally. The Federation of State Medical Boards, the AMA, they are willing to step in and support your state associations and your state medical board in these endeavors. They are big supporters of the model, and they are ready to lend their hand and support. And I don't think I'm overstating that.
Dr. Balad, followed by Dr. Yip.
Thank you for this excellent presentation, Drs. Bundy and Early. Wanted to just ask a few questions, specific ones. You mentioned the importance and showed the pie chart of the UME problem. And if we look at that, various medical schools will implement curriculum towards that end, and some may not. So meaning that by the time the person is in UME, undergraduate medical education, and then they move into GME, I think that one of the issues that I would like to hear, what I'd like to hear from you is, what have you noted to be useful to DIOs and program directors? Because it is a real challenge, because it is a blemish oftentimes if you're a program director to have to say, this resident isn't making it, because hundreds and hundreds of people were applying to my program. I picked this person, and now this person isn't working out. I'd like to hear that first, and I have a couple follow-up questions.
Dr. Balad, could you say what UME is and what GME is?
Yes, UME is undergraduate medical education, and GME is graduate medical education. So those are your residents, fellows, and undergraduate are your medical students.
Well, I can describe a couple of different real world examples of how things have worked for us. And first of all, when you have a medical student at a UME or a resident in a GME situation, you're right. The schools are really invested, and the people, when they call me, they almost feel like, oh, I just thought this gentleman, this woman was doing so well, and now we have all these problems. And the first thing to do is to say, yeah, statistically, we're all doctors in that case. Statistically, a certain percentage of your people are going to develop the problem, just like they're going to develop, some of them are going to develop diabetes in their life or hypertension. And so that's an inborn error of prejudice against mental health conditions, especially substance use disorders. It happens. The successes we've had have really come when we've taken a resident who is underperforming and has some depression and maybe an alcohol use disorder, and we return them to work, and they call me up, the residency director calls me up and says, oh my God, who's this person you sent back to me? They said, all of a sudden they're awake, they're alive, they're as bright as they were in the interview. And I say, yeah, that's what happens when you get healthy. And so it's in the real world trenches that you repair the inborn error of prejudice against mental health conditions, and that these folks really become, you only need one or two successes in a residency program before you convert, or a medical school before you convert to, you really change the attitude within the system, which unfortunately is not the case in the practice world, unfortunately. But I will tell you, let me tell you one other quick story. We had a medical student who developed a substance use disorder at a major university you would recognize in the Atlanta area. And he really had tons of scholarships, had taken out tons of loans. He didn't have much money. The school, that was what I was saying, the school actually found a way of help supporting that individual to help support his treatment. And then, and in doing so, they all engaged in the health of this individual. That person is now back and is finishing up their 4th year and is matched in an eminent program, and is doing super well. And they actually found money for this person because they were so clear about the fact that of its benefit, especially when you catch it early. When you catch it early in a medical school setting, when you catch it not quite as early in a residency setting. And it also perturbs, obviously, a residency, where everyone's working their behinds off, right? But then when that person gets back, the whole group rallies around them. So it naturally creates its own enthusiasm in these smaller systems that are dedicated to education. And so I want to give you a positive. It will show up in your fine medical schools in California. The more that you get people into the program, and then they become ambassadors for getting care for other students or other residents.
Dr. Yip?
Oh, okay, may I ask a follow-up?
Oh, I'm sorry.
Yeah,
My
that's
apologies.
okay. No worries. Another follow-up to that, and thank you for that. It's inspiring to hear, because I know I've worked in this sphere for a long time, and you do see some really impressive people suffer and then they come back, which then brings me to my next point, and that is, I was very happy when Samsha and everybody in ASAM talked about addiction as a chronic disease. This is not a one and done for most people. And so when I will echo, I sit on panels, and uniform standards are sometimes very difficult to apply, right? Because you really have to understand the circumstances, and I think you have to understand the disease and of addiction. And so to that end, you provided really stunning statistics, right? Because within 90 days, if you go and you do medication-assisted treatment in the general population, you hope that 1/3 of the people make it, right? And here you have 78% in a 5-year period, and even higher if somebody has recidivism and they come back through the system. My question about that is the need for the knowledge of substance use disorders, and my question is co-occurring. What percent do you estimate in your populations, in your PHPs, have co-occurring illness? Is it a lower number, higher number, just like would be just like you would imagine for the prevalence within the general public? Because doctors are humans, which is your first comment on your slide, which I thought was very important. So, is there anything you can say to allay I think you laid it out, the fears that maybe our healthcare consumer advocates have, but the program itself and its outcomes speak for themselves. And have you put together any campaigns for specifically healthcare consumers to help medical boards, or you have resources?
It's actually, I mean, I'll take that one. We do a lot of education outreach. My comms manager is actually attending this meeting today, probably grading my performance. I'm probably going to get some harsh feedback later. We are always looking at key messaging and how we communicate with all of our stakeholder groups about who we are and what we do. I would say that, California is exceptional in so many ways, right? You guys have alluded to it multiple times here, and I think it's wonderful. I love California. I spend a lot of time there when I can. The issue with consumer groups being opposed to the model is unique to California. I virtually hear none of this in any other federation state where there is strong consumer advocacy against what the PHP model is and what it stands for. You have a unique situation there, and I think, and I want to say that because I think that one speaks to the answer of why we don't do a lot of targeted messaging just to consumer groups, because that actually isn't, actually where we deal with most of our problems from a public relations standpoint is actually individuals who have not been served well by the PHP in their view. They've often ended up having discipline. They've often ended up not being able to continue in the profession, and then they've become very loud and very vocal on social media talking about the injustices that have been done to them as a result of the medical, industrial, and PHP complex. We live in a world of polarization and mis and disinformation, and it's out there for us too. But that's where we see most of the criticisms of PHPs coming nowadays is that we're being too harsh for the doctors that we're seeing. We're not being compassionate enough. So it's an interesting dilemma for as you phrase it, because we've actually spent a lot more time thinking about how we can tell our story in a way that reassures that we are finding that balance. But more so, the pressure seems to come these days from the, why are you asking physicians to do these expensive out-of-state evaluations, and you must be getting kickbacks for it, and there must be nefarious motives behind what you're doing, and I don't think so, but that's where the short answer is I don't have a lot of ready to go messaging, but that is definitely something that should be thought about and should be considered, because obviously those groups are an important group of individuals. I think the history of PHPs is that we really kept a low profile for the first 30 years that we did this, because we were wanting to protect the confidentiality of people in our program. But when the pandemic started, it became okay to not be okay in medicine. It became okay to start being vulnerable. People started telling their stories more publicly. And people became willing to give up their confidentiality and their anonymity in the service of reducing stigma and being a resource and support to their peers. And so that kind of ushered in a new era of public relations for the Federation of State Physician Health Programs and individual PHPs, because largely we would just ignore some of those more crazy criticisms, just keep our head down and try to protect the people that whose confidentiality we were supporting, and couldn't really ask or even count upon people who were benefiting from the confidentiality in our programs to come forward and tell a different story of their experience. Now we're differently positioned to be able to tell those stories. So I think, everybody has a perspective and a testimonial and a narrative. And so, your patient advocacy groups, they have a narrative, and that's their lived experience, but we also have other narratives and other lived experiences that need to be heard. And so, to your point, I think putting heads together around that messaging and really understanding what we're talking about here in a deeper way, in a more nuanced way. Simple solutions come from simple explanations, which tend to not solve any of the complex problems.
Yep. Dr. Yip.
Thank you so much for the excellent presentation. Congratulations on success too. My question, also some comment, is that what has been your experience in Washington and Georgia and any state of the federation of the board that an effort made with the legislation and the insurance company, HMO, IPA, like Ford Foundation, Kaiser, etc., to really recognize healthcare worker stress or minor so-called mental illness as a medical necessity that they can be paid for. Obviously, with finance, one of the problems that we're facing, and we're going to add $20 to the surcharge, but probably it's not enough. I think California, we're going to look at this angle. Elaborate, Dr. Dingman, Ms. Watkins, that I had the idea to also work with legislators, also with support of AMA and CMA, and hopefully insurance companies that lobby to get those medical necessity approved so that they can be paid for in the future to make this a successful long-term program. The other question I have is that when I was reading Carrie Webb's excellent preparation, I made a lot of notes. One is that we are different. We pay a lot of emphasis on our public advocates. And what do you think, I'm looking at in the future, we're going to start one way or the other. And we have a PHP independent but part of the board that one board member, one public member sit on so-called a board or management council or management meeting every quarter as a member at large. Since you mentioned transparency program, patient name, physician name, all black out, but at least we can look at the data, how the program is going, the number of physicians that drop out, etc., more regular basis, and even to the point that one of the consumer advocate being a member at large in those meetings because we emphasize transparency. I think that's one of the ways that we can gain trust and understand all parties, the difficulty and challenge we have to make something that works. Do you have something like that in your program state?
So in Georgia, again, we're a smaller program. I'll try to answer the last question. Please, I might need refreshment about the first question because it slipped out when you got to the second one. In Georgia, we have a smaller program, and on our board of our PHP, we have an ethicist who is from a major university who does medical ethics work. We have an attorney who works with physicians and other people in various medical malpractice and other issues. We have several physicians from one who is on the board of the largest malpractice carrier in the state, and one other person that tends to represent the public and their interest. And that's on the board of the PHP. And we talk in general about our data in that group. I will tell you, and I think Chris will back me up on this, that of all of the jobs I've had in my life, this is the one which requires an enormous amount of nuance in decision-making about what to do next. that some of the startling things that I've had is I've had physicians that have been extremely ill just come back and do very, very well. And then I've had other physicians that are not so ill in terms of their depression or their substance use disorders that we can't seem to help and need to wind up eventually giving up their licenses as a result of that. And so it's a lot of the rules I learned earlier in my career have to be rethought. And that's where I rely in terms of my supervision on people like Dr. Bundy or some other people in the state. And we all talk amongst ourselves and say, what do you think about this case? Because this is a very unusual kind of job. And there are not many of us that do this type of work. And so that's important. But I do think that talking about individual cases to our board is not, in general, does not yield much fruit. There are times when I do that when there are concerns about liability for the organization, or at times when I'm worried that I have to, frankly, tell the medical board, look, I think you need to worry about this case, because they have, over the years, we've been around for only 10 years, but over the 10 years, they've become pretty feeling like, geez, thank goodness we don't have to worry about this anymore. So some of the times we have to kind of ring a bell, if you will, with the medical board and say, look, this is a case you really need to worry about, just because of our experience and the experience of our peers. And I don't think I answered your first question very well, but hopefully I answered the second one at least a bit.
Yeah, I think our experience in Washington is similar. We have public members on our board of directors. We have public members on our medical board. As I mentioned, we collaborate closely with our medical board on all kinds of issues. I think that that open line of communication. I think Micah Matthews, who's our deputy executive director, has had some dialogue with your staff about how that works in practice, so that they, to deepen that understanding of how that collaboration works and how that input works. We are really just in the early days of thinking about how to properly advocate for who should pay for necessary services. Dr. Early, actually, along with Drs. Paulus and Barron, Dr. Paulus is from the Florida Physician Health Program. Dr. Barron is our current FSPHP president and runs the Tennessee program. They authored the ASAM chapter on safety-sensitive workers, and that just came out. That is hot off the presses, and it is a tour de force. It actually will help us go a long way in advocacy efforts, hopefully with insurance companies, to say, these are the rules. I mean, these are the rules for safety-sensitive workers, and they're a special population, and not paying for care out of network for the special services that's needed isn't okay. And we're hoping that we will be able to get others involved, AMA and others, to look at legislative solutions and other solutions. I'm also working, actually, frankly, with professional liability insurance carriers as a sublimit option, so that PHP necessary services to stay in practice might actually be an offering by your professional liability carrier. So, we're looking at various options to help mitigate cost burdens to participants, whether it's on the health insurance side, professional liability insurance side, or other. We're looking at those things.
That's wonderful news. Thank you.
So if there are no members who have not spoken once, Ms. Lubiano.
Thank you. And excuse me for a second, I'm battling allergies today. Thank you to staff for all the materials on this agenda item. I could see how you had to be very meticulous to go through each and every comment, so I appreciate that, and as well as for the concise summary and chart. Thank you. Dr. Early and Dr. Bundy, thanks for being with us. In front of us is a PHP program that we see that does not incorporate some of the best practices. And so I believe that in reality in front of us is that if we wanted to modify the regs to include those best practices, we would have to rely on legislation, which can take time, and effort. And so, in your opinion, do you believe that it is better to be completely without a program for some uncertain length of time versus a program that's not perfect but could be a potential option for physicians?
I'll speak my opinion very quickly, clearly, and then I'll let Paul speak his. I would not waste time, energy, and resources in doing a program that is going to not be well utilized and not serve people well. I think you would be better time spent diverting that energy and that time and those resources into a definitive solution.
So I'm going to echo, unfortunately, I get the idea about we could create something now, even within the current standards. But the problem with that is, I will tell you, is reflected to some degree in what happened in Georgia. We were able to get a legislation to empower a physician's health program in the state of Georgia. But the legislature, in its wisdom, decided to do nothing about its funding. And now we're deeply hamstrung by that. I'm a part-time employee. We have 2 full-time employees, and we have 2 other part-time employees besides myself. And we scramble, and frankly, I work full-time getting paid for part-time, it's okay. I'm getting older. I love the work. That's okay. But it's not sustainable. And the other problem is with your current uniform standards, they feel like they put the program in such shackles that I worry. Not only would I worry that it would become stagnant and cast in stone, I don't know if it would be effective. And then what would happen is a pushback about saying, well, this isn't working. And so the natural human attitude is, well, this isn't working. We need to get rid of it. So I just really worry that unless you have a system which is built with all of the brilliance of some of the other things that California has contributed to the United States, you can do it. I get it that it's a heavy lift, but I do think starting with the legislation is the way to go if you're going to sustain a long-term program which is of the quality that the medical board is going to be proud of and that the safety of all Californians is going to be helped. Those 2 things, I unfortunately would require the ability to have anonymity in the programming and to have a robust program, not the least of which is you've got 119,000 physicians in your state. So you got to have the funding to make it work, and you're a distributed state. Chris and I were talking, and Chris said, well, they're going to have 3 medical directors, a north, a central, and a south or something. I mean, it's going to be, we can help you build something like that, but if you build an inadequate model, there's going to be finger pointing about the fact that it's a failure, and you run the risk that it will fall apart.
Well,
Thank
Drs.
you.
Bundy and Early, I want to thank you really for a priceless interaction between the board and the consumers and all physicians who are on the line or will review this on our YouTube reposition of this quarterly meeting. We really appreciate you very, very much. And again, it is priceless.
Thank you.
We'll come back anytime. Here for you.
Excellent. Thank you to the staff, to echo Ms. Lubiana. Any comments from the public present in the hearing room? Okay.
Good morning, board members. My name is Marcus Friedman, Administrative Director for the Consumer Protection Policy Center at the University of San Diego School of Law, formerly known as the Centers for Public Interest Law. We are a nonprofit, nonpartisan academic advocacy center at USD School of Law. We've examined and critiqued California's regulatory agencies for 40 years. One of the first things I wanted to point out in the presentation today was that both in Washington and Georgia, they created the establishment of an independent board separate from the licensing state agency. That board, and I encourage each member to look up online on their website, in Washington, there's 13 board members that are dedicated solely to overlooking that program. As well as in Georgia, there's 10 board members that are solely dedicated to overseeing the wellness program. They also have their own staff that solely is dedicated to the program itself. I'll remind this board that in the previous substance abuse monitoring program that the medical board had, within its 24-year existence, it was independently audited 5 times, and it failed each audit. Some of the common problems were understaffing, lack of resources, inability to detect relapses, and the board's failure to adequately oversee the program. After the 5th failed audit, the board voted unanimously to end the program in 2008, and it led in part to the creation of the Uniform Standard Codes. I believe that these are important considerations for the board to think about as they're considering whether or not to establish a new substance abuse monitoring program. As previously shown in the history, this board has failed to adequately oversee such a program. I think the question that the board needs to ask itself is not whether or not such a program is necessary within California. It's whether or not this board is able to oversee such a program. Given, as we see from the success from Washington and Georgia, that they have their own independent board, separate from that state licensing agency. And it's true the state licensing agency does have some approval power on how the program is run, but they're 2 separate entities. And I think that's something that's important when considering what to do next for the medical board. Thank you.
Good morning. My name is Dr. Shannon Udovic-Constant, and I am a pediatrician practicing in San Francisco, and I'm the president-elect for the California Medical Association. And I'd really like to thank you all today, as well as our speakers, for including this PHP agenda item and the thoughtful consideration of this critical issue. The panel and the materials the board staff put together, and I echo the thanks for excellent materials, provides important context. And over the course of the board's meeting, you've heard a lot about the burden that the stigma against seeking care and the inability to access care can create. And this is an issue for both physicians as well as all of our patients. California is often on the cutting edge, as we've already talked about here, and yet here's an area where we have some opportunity. And we are lagging, and it's now the time to correct that. So we ask that the board position itself to welcome and engage in developing a PHP program that meets national best practices. And in doing so, the medical board will maximize its ability to protect the public by creating a supportive environment for physicians to seek help before the mental or behavioral health issues get to the point that they're creating the impairment. I'm a pediatrician. I believe in prevention. So, currently, California physicians with illness have limited options and understand that seeking care may threaten their ability to practice. And this leaves physicians in hiding, as we saw from the numbers from the other 2 programs, and then not with treatment. And the physician health program that uses the best practices will encourage physicians to refer themselves and their peers in need of support to a program, knowing that that participation won't jeopardize their careers unless there is the harm. Physicians are committed to providing the best patient care. When we have questions about patient care, we reach out for consults. When we have questions about our own self-care, physicians don't feel like they have anywhere to go. Medicine is not just about diagnoses and treatments. It's about relationships and trust, as we've also talked about this morning. And to encourage the best patient care, we should support helping physicians show up as their best selves to create a program that they can trust, that will support them when they need it. CMA has been steadfast in calling for California to fill the void that was created by the dissolution of the diversion program in 2008. A program that meets national best practices can't exist without robust cooperation from the medical board. I will reiterate CMA's ask that the board take this opportunity in this moment to lend its support for building a physician health program in California that is modeled after the many programs across the country that have proven to enhance the lives and those of our of the physicians and the patients. And I can assure you that CMA stands ready to partner with the medical board and other stakeholders in next steps. Thank you very much for your time this morning.
Good morning, and thank you so much for giving us this information that we've just received. The independent individual PHP can have a grant writing department with a straight salary plus commission in order to fund it, which provides incentives for when you have them on commission instead of just straight salary. That provides incentives for people to go after the funding that's needed for the organization. In working in colleges that I have worked for, within generally departments would have about 5 people in the department working, and we raised like mega amounts of money for whoever, whatever the focus was at that particular time, even if they had to give a festival and get Chase or somebody to come in and put up 100,000 or so, So that's one of those things where we can raise the money because it's in the public, because even the public would help to raise the money if you're doing different activities that brings them in. Now, Jesus said, physician, heal thyself. And we can't be at the point where we let the doctors walk around not feeling good, being addicted, or things of that nature, because so much pressure is on a person. They see so much life and death and illness, so they have a lot of pressure on them, period. So it needs to be where their insurances cover them, for starters, and you would be surprised how many doctors that I've known of who had suicides and things of that nature. So we have to care for the people who are caring for us. Now, there is a way we could give the doctors treatment plus monitoring when they come back to work, because they could be like in maybe sort of an initial apprenticeship situation when they first come back to work. So somebody is there to help them out along the way. Now, when you get to that emphasis on uniform standards, going forward of the extreme necessity for professional care for the doctors and the public and the community, in order for us to have confidence in our healthcare and practitioners, we really need to have the results of any inquiries and investigations based upon that standard, uniform standard. And keep that open to where people can find out, even if names have to be redacted. And along with that, if we don't have a serious trust of people for doctors, at some point along the way, they'll be like me, because I've told people, don't take me into that hospital unless my head been cut off. We're basically looking at the idea that, even you go online, you see WebMD and things like that. There are things to eat instead of us being stuffed full of a lot of pharmaceuticals. But in the meantime, our doctors should not have to be so pressed. Like when I was performing over in where is that? We would tour colleges in Houston area. One of the guys that was working in our band was a pharmaceutical salesperson, and we found out that people were getting paid for pharmaceuticals, issuing. And I think I talked too much because I see the red light. I love everybody. God bless everyone.
Comments for those on WebEx?
The hand-raising feature and the Q&A window open. Anyone who'd like to make a public comment, please go ahead and queue up. First up here, we have John Rosenberg. John, let me find you in that list. John, you should have received that prompt.
Hello, can you hear me?
We can, please go ahead.
Good, right, thank you. Good morning. My name is John Rosenberg. I'm a psychiatrist practicing in Berkeley, where I specialize in evaluating healthcare professionals with psychiatric, substance use, aging, and other potentially impairing conditions. But I'm speaking to you today as the chair of the board of California Public Protection and Physician Health, referred to as C3PH by many, including Dr. Early earlier today. C3PH was established in 2009 by the California Medical Association, the California Hospital Association, California Society of Addiction Medicine, and the California Psychiatric Association. After the medical board's diversion program was closed, C3PH was formed for the purpose of supporting those in medical staffs and medical groups who identify, refer, treat, and monitor physicians with potentially impairing conditions. For the last 15 years, C3PH has published guidelines and provided ongoing information and education for hospital medical staffs and medical groups as they address alcohol and drug use and addiction, psychiatric disorders, cognitive functioning and aging difficulties, and behavioral issues among members of the medical staff. These problems that must be recognized as early as possible and effectively handled in order to protect the patient care delivered in our medical institutions. On behalf of C3PH, I'm speaking today to encourage the medical board to continue your efforts to provide California with a physician health program that functions in line with recognized best practices, as you've heard about today, and that will take advantage of the experience of programs across the country to reach the level of effectiveness in early intervention, rehabilitation, and patient protection that those programs have demonstrated. We look forward to the opportunity to partner with you, with the medical board, as has been suggested today, as you move forward in the development of such a program. Thank you.
Thank you for your public comment. Next up here, we have Kimberly Turbin. Should be receiving that prompt.
Good morning. My name is Kimberly Turbin. I'm from Stockton, California, and I'm a volunteer with Consumer Watchdog. I have 2 young children, and I am responsible as their mom to choose the best possible healthcare provider for them. Listening to this meeting for the past 2 days has left me with incredibly worried about the fitness of my children's doctors. I count on you, the medical board, to regulate our physicians and present to us physicians that are not substance abusing doctors. I don't think that that's a lot to ask. Their competence level, their ability to provide adequate care, I can manage that for the most part. But how am I supposed to determine whether my children's doctor is a substance abusing physician? I count on this board to protect my children and ensure that their doctor is not impaired. I don't have faith that this board is willing to protect my children. I have heard you provide excuse after excuse after excuse for the impaired healthcare professional. Is the program confidential enough? Will certain questions trigger anxiety for them on licensing applications? Will the required reporting of their program rehab failures cause every participant in the program to be reported to the board? Well, it is simply follow the program. Interested parties are concerned that their participants will not be able to afford to participate in the program because they are responsible for paying for all the costs of the program. If they commit a major or minor violation, they are subject to being reported to the board and may face discipline, which would require them to pay the board's cost recovery. Well, if the costs are too much, then go into a private program. If you don't want to pay the cost recovery, then follow the program and don't violate it. The rules are really simple. Follow the uniform standards and set the program in place as the rules are currently set. If a doctor can't afford the program, then they can go into a private program. If a doctor truly wants to set a path for recovery for himself or his family and his patients, then they will follow the program violation free. I am sure that most of us have children and would have the same concerns as I do. I'm not hearing any concern from my children. Maybe when you vote on this program today, you should keep your children in mind too. Thank you.
Thank you for your public comment. Next up here, we have Michelle Montserrat Ramos. You should be getting that prompt.
me?
Yes, we can, Michelle. Please go ahead.
Hi, I am Michelle Montserrat Ramos. The tragic death of my husband-to-be, Lloyd Montserrat, brought me to this board and has kept me in front of this board for 17 years, advocating for you to protect us, the public, from substance abusing physicians. What are we talking about here? Our value as human beings versus the value of a doctor's livelihood. The majority of this board has shown us that although it is your mission to regulate licensees and protect consumers, you're placing more value on the livelihood of substance abusing physicians than on our lives. The concern with the costs the physicians will have to endure with this program. We know that any impaired physician can go to one of the countless rehab programs in the state, and the board would never know they were there. There would be no concern for having to pay cost recovery back to the board, which we advocated for you to receive, because again, they could fail the program and there would be no consequences and no public safety. There is no need to debate the confidentiality of this program because there are private confidential programs where addicted doctors can go to. This program will be confidential for the participants as long as they don't commit a violation. So don't commit a violation. There's no need to debate over worrying about every doctor ending up being reported to the board because they violated the program. They could go to a private program and do whatever they want, and we, the public, would never know. This is really simple. Follow and maintain the uniform standards. We have seen some incredibly egregious cases this year with doctors impaired while on duty, passed out in bathrooms while patients waited for them in the OR, ending up with modified orders. Also, according to the Osteopathic Medical Board, the vendor Maximus is not reporting the violations to the Osteopathic Medical Board, which means that Maximus is not following the uniform standards. We understand that the standards are put in place to protect physicians who really want to change their lives. Healthcare providers are coming to us and asking us for help because they can't understand why the board is allowing impaired physicians to continue to practice, putting them, the other healthcare professionals who do not practice while impaired, at risk. Board staff was upset and asked why healthcare professionals are coming to us and not to the board. Well, maybe that is a question you need to ask yourselves. You have a responsibility to protect the public and other healthcare professionals who are being put at risk by allowing known impaired physicians to continue to practice unrestricted. Thanks to the uniform standards, we do have best practices in place that protects the public, the impaired physician, and the healthcare providers who have to work with them and are currently being put at risk. When you vote today and in panels, think of your family's life and welfare when you vote. The next person harmed or deceased could be someone you love. The uniform standards are key to protecting all stakeholders. Thank you.
Thank you for your public comment. Next up here, we have Paul Yoder. Paul, you should be receiving that prompt.
Morning. Paul Yoder on behalf of the California State Association of Psychiatrists, CSAP. CSAP would like to affiliate itself with the comments made earlier by the California Medical Association. Burnout is real, behavioral health issues are real, SUD issues are real. Physicians are humans, and they can, when they run into difficulties, they can and they do get better. I asked the board to please support the creation of a physician health program that will align with well-established national best practices. Thank you for your time today.
Thank you for your public comment. Next up here, we have David Granovetter. David should be receiving that prompt. Good morning, David. Looks like your line's open. Are you there?
Yes, can you hear me?
We can. Please go ahead.
Okay, thank you. So my name's Dave Granovetter. I've been a practicing physician for 45 years, 35 of those in California. I have over 20 years experience in addiction medicine and working in physician well-being, working within a large medical group setting. I'm also closely aligned with C3PH that we've heard about several times this morning. And I'm also here to, echo some of the concerns regarding the proposed regulations for the California PHP. Now, I'm also a physician in long-term recovery from the disease of addiction. So I had successfully completed a 5-year monitoring program under the board's prior physician health program, known as the diversion program. So I can attest firsthand to the life and career-saving benefit of PHPs. I've treated thousands of patients throughout my career, and I certainly hope that has been able to save additional lives. So as a firm believer in the model of PHPs described by Doctors Bundy and Early, and the model existing in many other states advocated by the Federation for State Physician Health Programs, I've seen firsthand how these programs can be instrumental. They're essential for public protection by facilitating early identification of physicians with impairing or potentially impairing conditions, and by providing the necessary resources for these physicians to get the needed help and to continue practicing safely and effectively, benefiting both the public, the entire medical community, as well as themselves and their loved ones. So, I urge the board to continue to reconsider and renew regulations and work towards developing a program, aligned with a broader scope, stronger confidentiality protections as discussed earlier. And by doing so, we can ensure that the California PHP can fulfill its potential to protect the public and support our physicians in need. So let's all continue to work together to get it right. And I'm more than happy to work with the board in that regard. Thank you for your time and consideration.
Thank you for your public comment. Next up here, we have Alka Ari. Should be receiving that prompt in here. Good morning, Alka, are you there?
Yes, can you
Yeah,
hear
we can
me?
hear you. Please go ahead.
Perfect, great. Thank you. Hello, I'm Alka Ari from San Francisco. I'm a volunteer with Consumer Watchdog. After losing my sister to medical negligence, not by one doctor, but several doctors, I lost faith in our healthcare system. Since her death, it's been disheartening to see how government oversight agencies go out of their way to protect negligent doctors without considering the patients who are injured or killed and the families that are left to pick up the pieces. Hearing of substance abusing physicians who are impaired while on duty in the hospital, with patients waiting for them in the operating room, is an unacceptable situation at every level. It's one thing to be impaired while off duty, but while on duty, it shows a complete disregard for patient safety. It's frankly arrogant, and this board shouldn't be condoning this behavior or helping physicians hide this behavior from their patients. Rehabilitation is a complicated subject, but we have to ask whether patients should bear the burden of risk rather than the negligent physician. Life is hard, not just for physicians, but for everyone. If a physician lacks the moral courage and emotional intelligence to step away from their career and deal with their substance abuse issue without compromising their patients, then they don't deserve the privilege to treat patients. We all want to be sensitive toward those struggling with addiction, but there is a difference when it involves a physician and an operating room. Between yesterday and today's meetings, I've heard a lot of comments exhibiting compassion towards substance abusing physicians, but I've heard little to no concern for the welfare of the public. Where is the compassion for patients? This board's overconcern with a confidential track for this program does not sit well with the public. The program is confidential for the physician participant, and the veil of confidentiality is only lifted once the participant violates the program. This is where the uniform standards come in. The uniform standards are there to provide protections where the former diversion program failed the public. You should want the participants to follow the program and have a successful outcome for themselves and their patients. Thank you.
Thank you for your public comment. Next up here, we have Marion Hollingsworth. Marion, you should be receiving that prompt.
You hear me?
Yes, we can. Please go ahead.
Uh, Good morning. My name is Marian Hollingsworth, patient safety advocate. Regarding the Washington expert who says California needs to drop the uniform standards, doctors as a group are usually arrogant, often believing that the laws don't apply to them because they're on society's doctor pedestal. This is obvious by the sheer number of disciplines this board gives out for behavioral issues, not surgical errors. They know they can get away with breaking the rules because they rarely get caught. Doctors routinely get DUIs or steal meds from the OR and still keep their licenses. But thanks to uniform standards, they have accountability. They have to undergo biotesting and other conditions. In recent months, 2 anesthesiologists were given stiff disciplines for using while on duty. They were allowed to keep their license, but they have to obey the uniform standards as part of that probation. This is an added layer of protection for the public. Taking away uniform standards to conceal a doctor's impairment doesn't serve public safety. Regarding the Georgia experts, airline pilots do undergo routine testing and have rules like not drinking within so many hours of flying. We assume pilots are safe because of those rules, those uniform standards, so to speak. We can't say the same for doctors. There is no assurance that a surgeon didn't drink or take pills before walking into the OR. When California tried to pass a proposition requiring drug testing for doctors, this board and the CMA screamed bloody murder, claiming that doctors would flee the state and we would all die. So as a result of this doctor hysteria, Californians don't have any assurance that their doctor is safe. A PHP without any net of uniform standards or accountability or some kind of public notice leaves us all at risk. It makes having a license mean nothing aside from the fact that the doctor paid for his license, just like he would pay for a bottle of booze. It also takes informed consent away from consumers, the right to know the risks and benefits of any procedure. Having a doctor who is an addict is a huge risk. Are any of you board members so confident in this program that you would go under the knife with an impaired doctor? Think about that. Regarding the trust of the program issue, advocates already don't trust doctors because either we or our loved ones have been harmed or even killed. And we know we can't trust the board to have our back because 96% of the time, the doctor complaints don't result in any discipline. So why would we trust a program that gives a safe, confidential harbor to addicted doctors? You know, the purpose is protect the doctor's license, not protect the public. The Georgia expert's opinion to just break the rules of uniform standards if they don't serve doctors just adds to the mistrust and shows the arrogance. And by the way, advocates aren't against treatment. We just want to know who's a risk to us. And I keep reminding the board that your mission statement says to regulate doctors to protect the public. Please don't ignore that. If you do approve a PHP, please don't make it confidential and please keep the uniform standards for the protection of patients. Thank you.
Thank you for your public comment. Next up here, we have Maria Ibarra-Navarrete. You should be receiving that prompt on your end.
My name is Maria Ibarra-Navarrete. I am from San Jose, and I'm a volunteer with Consumers Watchdog. Many, like myself, trusted the person with the white coat, our physician. Unfortunately, the medical negligence behind my brother's death changed that perspective. When I come to these board meetings and listen to the stories of negligent physicians that have caused harm to innocent victims, it baffles me. When a physician takes the responsibility of caring for the health and providing care to the communities they serve, it is a privilege. It is trust that is established between a doctor and a patient relationship. But when that trust and doctor responsibility is compromised due to substance abuse, we cannot allow them to practice medicine under any circumstances. It is imperative that before substance abuse physicians are allowed to practice medicine after the program, that a strategic plan is in place by this board. The Uniform Standards is the law and lays out a strategic plan that allows for the evaluation, monitoring, and if the doctor violates the program, then discipline. Holding physicians to a high standard is important as we, the patients, trust them with the lives of our loved ones and our own lives. Why are we allowing physicians to fall below a standard that we must hold them to? Your duty is to protect the public from harm and prevent physicians from continuing to harm patients. In our complaints, they are evaluated by a standard of care or a departure from the standard of care. Why are you not seeing that substance abuse is an extreme departure from standard of care? The Physician Health and Wellness Bill was drafted in 2008 and presented over and over again until it passed both houses in 2016. The Medical Association and the subject matter experts, as you referred to, them drafted this bill to only include physicians and surgeons. If they wanted to include medical students, they should have done it then. As we all know, medical students are free to enter any rehab program of their choosing located throughout the state. I don't see how you feel that the third party will serve providers that will run this program will not be independent of the board because they will be required to report the board any violations of the uniform standard. You had a fully independent program before that failed California consumers. It failed so badly, and that is why we are here today. Providing consequences and making the service provider report failures to this board is not a negative. It is a patient safety positive element that was created by the standard to protect substance abusing physicians and their patients. You have always talked about the trust doctor-patient relationship. There is nothing more that could break that trust than allowing a known impaired physician to continue to practice unrestricted, putting themselves at risk as well as us and their patients. Thank you.
Thank you for your public comment. Next up here, we have Bernard McNamara. Bernard, you should be receiving that prompt. There you go, Bernard. Looks like your line's open. Bernard, are you there?
Here, can you hear me?
You sound very far away from your device. If you could come closer.
Can you hear me now?
Just barely, Bernard.
All right.
Sounds like you're across the room.
So I'm right here. All right. Anyway, can you hear me better now?
For a minute there, it got very loud and then disappeared again.
I'm here. Can you hear me?
Bernard, we can hear you just very distant. We're going to go on to Tracy Dominguez. I'll come back to you in just a minute. Maybe you can get it worked out. Tracy, you should be receiving that prompt. Good morning, Tracy. We can hear you. Please go ahead.
Good morning. I'm Tracy Dominguez, and I am from Bakersfield, and I am a volunteer with Consumer Watchdog. Protecting patients or protecting the livelihoods of substance abuse physicians. That is what we're really talking about. As you know, I lost my daughter and my grandson to maternal negligence. I also have other children and grandchildren that I need to worry about when they need care in a hospital. Who's going to protect them? Before my daughter died, I would have counted on you to protect them, but I know now that I can't count on you. This decision and over concerns for substance abuse doctors has confirmed for me that the public is on their own. The livelihood of our doctors is more important than the livelihood of our children's life. Your vote will decide on my other children should face harm or die, or you're going to hold substance abuse doctors accountable as the uniform standards require you to. This is simple. If the program is too expensive for a doctor, then they go to a private rehab program. If the doctors don't want to pay back the board for the cost recovery, then they don't violate the program. If this board is more concerned with the doctors losing their confidentiality, then they violate the program. Then again, don't violate the program. They should follow the program because they want to beat their addiction for themselves and their family and for their patients. One of the representatives claims that the substance abuse physicians are human beings and developed illnesses before they became addicted, but the public isn't buying it. Addiction is a choice. How do you think I survived my extreme grief? I had no choice. I could have chosen to hide my grief in substance abuse, but I have chose to advocate. Now you have a choice. You are going to choose. Are you going to choose to protect me and my children and the public? Or are you going to choose to protect the livelihood of a substance abuse physician? Make the right choice. Today, my daughter, Taylor, turned 24. She is celebrating her birthday with her family. She had her baby in a different town. She left the Central Valley. In 15 days, Demi would be 29 years old. She would be celebrating her birthday with her son, but this board chose not to protect her. You chose not to protect her. Please make the right decision now and protect the future. Please don't let another mother go through what I had to go through. Thank you.
Thank you for your public comment. Coming back to Bernard. Bernard, you should be receiving that prompt. Let's see if we can hear you now. Bernard, are you there? Sorry, Bernard. Now we can't hear you at all. I'll try to turn up the audio here in the room. We can very faintly hear you, but please go ahead.
Yeah, I'm here. Anyway, I'm here. I'm Dr. Bernard McNamara, an addict myself. Sobriety date is February 5th, 2001. Actually, I went through the Washington Physicians Health Program. I came in voluntarily when Springbrook Northwest Treatment Facility in Oregon, which is now part of Hazelton. I thought the Washington Physicians Health Program was great. It helped me tremendously. Sober ever since. Then I came back to California. I still have my license in California. And I became part of the diversion program here, and I graduated in 2007. So went through 5 years here after going through about a year and a half of Washington Physician Health Program. It's a great program. I think the programs all have very high standards. I had to comply completely. It helped me tremendously, made me a better physician, and I'm very grateful for all that. I just finished joining the American Society of Addiction Medicine. I don't know what took me so long. I'm getting involved in addiction medicine as well. I'm already board certified in emergency medicine. So I think this program is fantastic. I think a lot of the things that made me hesitate about getting help and coming in, which I did voluntarily, was the shame that comes around this whole process of addiction. I mean, addiction wasn't my choice. I was probably born an addict and didn't know it, and you find out you're an addict the hard way. And so when I finally accepted the fact that I had the disease of chemical dependency, that I was an addict, I came in voluntarily and I went through treatment, and I did very well. But what keeps a lot of people from getting involved, whether you're a doctor or not, is the shame that goes around it. The shame for you and your family and the people you know and work with, and also the prejudice, my own prejudice, and prejudice of the people around me. But I'm very grateful. I'm in recovery, and I don't regret it one bit. I'm a much better person because of it. I certainly would advocate for having the physician health program in this state. It sorely needs it. It would absolutely protect the public. More doctors would get involved and come into treatment and get the help they need, and that would be much better for the patients, believe me. And that's all I got. I really appreciate your talk, and shout out to Dr. Bundy for all the great work you're doing in Washington. I loved it in Washington, I love it in California, and yes, we definitely need this. It'll be a great help for physicians and patients alike. Thank you.
Thank you, Bernard. Just turn it down here a second. At this time, Dr. Hawkins, I don't see additional requests.
Thank you very much. I want to offer a 15-minute bio break and stretching break. I want to indicate when we come back, agenda item 12 would be discussion and possible action related to the rulemaking on the Physician Surgeon's Health and Wellness Program. The process will include Mrs. Webb giving a presentation, I will then ask for public comment. I then will ask members to each give a limited take-home from this discussion. I hope after that we'll be able to generate a motion. So we're on a 15 break. Welcome back, everyone. Moving to agenda item 12, discussion and possible action related to the rulemaking on the Physician and Surgeon Health and Wellness Program. Carrie Webb.
Thank you, members. I want to get a sense of the direction here before I suggest a motion. This is for the rulemaking for the Physician Health and Wellness Program. The proposed text is in there. The public comments that were received during the 45-day public comment period are in there, and the proposed responses. You have different options available to you. If this is not the program that you want to go forward with, then you can direct staff to withdraw the proposed rulemaking and bring back a legislative proposal during the November meeting. If you want to go forward with the proposed regs as they are currently written, then I have a different motion to suggest. But those are the options that are on the table right now.
So as I said before the break, although the public has just presented and they have had the opportunity to look at the information and know some of the comments they've made, recommendations, I wanted to ask for public comments again. Then I want to ask the members to each give a limited take-home from this morning's dialogue. And then I hope after that we'll have the ability to generate a motion to be voted on. So anyone in the room have a comment on this item?
Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. First, we would like to thank both the board and board staff for their thoughtful consideration of this issue and the associated regulatory package. As the original sponsors of SB 1177, the legislation authorizing the program, as Dr. Udovic Constant noted, CMA remains steadfast in its goal to improve physician health and well-being. After several attempts, CMA passed the best program it could get across the finish line at the time. Now, because there is a renewed interest in pursuing an improved program which aligns with national best practices, CMA believes it would be appropriate for the board not to adopt regulations to implement the program currently authorized in statute at this time. We request the board encourage its staff to collaborate with stakeholders on developing a program that aligns with what we heard from Drs. Bundy and earlier today. Achieving such a program is an important way to enhance patient protection by helping physicians show up as their best selves. Thank you.
Good afternoon, board members. My name is Marcus Friedman, Administrative Director for the Consumer Protection Policy Center at the University of San Diego School of Law. I previously testified at last quarterly meeting about our previous Administrative Director, Julie Thelmeth, who investigated and reviewed the Medical Board's Substance Abuse Monitoring Program in 2004. The program was audited 5 times, as I explained earlier today, in its 24-year existence and failed all 5 audits. The most common problems were understaffing, lack of resources, inability to detect relapses, and the board's failure to adequately oversee the program. After the 5th audit, the board voted unanimously to end the program in July of 2007, and it was abolished on June 30th, 2008. As I previously stated, the abolishment of the previous program in part led to the uniform standard codes that are in place today. At the last quarterly meeting, some board members were interested in other states' substance abuse monitoring programs, and we know that most other states have such programs and they claim to work well. I just want to advise this board that while we had the testimony from the two presenters today, it does not appear that they have been independently audited, similar to the way that the medical board's program was in its previous existence. Business and Professions Code Section 2001.1 states, the protection of the public shall be the highest priority for the Medical Board of California in exercising its licensing, regulatory, and disciplinary functions. Whenever the protection of the public is inconsistent with the other interests sought to be promoted, the protection of the public should be paramount. We are concerned that if the board members today are unable to actively supervise the new program or establish a supervising committee consulting of board members, then this program should not be pushed forward at this time as it conflicts with protection of the public interest. As we heard in the presentations earlier today, and as I previously explained, that separate independent board helps oversee and make sure that their programs are functioning correctly, something that this board has failed to do in the past when trying to implement their own substance abuse monitoring program. CPPC urges each board member to consider whether this monitoring program is truly a priority for the protection of the public interest. Nothing in the law requires the board to create a new program to monitor substance abusing physicians. And it's clear that any program created by this board must be consistent with uniform standards, which the inconsistencies in the proposed regulations are discussed in our written testimony that was submitted last fall. A no vote on this proposed regulation would allow this board to focus its time and resources on areas of higher importance for the public protection, such as licensing and enforcement. In light of this board's failed experience in overseeing a monitoring program and the mandatory statutory elevation of public protection over physician rehabilitation, we respectfully urge this board to reject the proposed regulations. Thank you.
Comments for those on WebEx?
The hand raising feature and the Q&A window open. Anyone wishing to make a public comment, please queue up there. We'll give you a few seconds. Not seeing any requests at this time. Sorry, late one just came in. Michelle Montserrat Ramos should be receiving that prompt.
Hello, I'm Michelle Montserrat Ramos. We all know that program planning has allowed to remain stagnant because of the uniform standards and the powers that be's wishes to eliminate the uniform standards. Without uniform standards, there are no protections for the public, for the impaired physician, and other healthcare professionals. Whether you move forward with a program regulations today or not, the uniform standards must be included in any planning of any program you plan for this state. Thank you.
Thank you for your public comment. Next here we have Marian Hollingsworth. Marian, sending you that prompt now.
Oh, can you hear me?
We can hear you, Marian. Please go ahead.
Good afternoon, Marian Hollingsworth, Patient Safety Advocate. I would like to agree with the Center for Public Interest Law and Michelle Montserrat Ramos and ask for a no vote on this item. I don't think the board has, considering its past record with handling physician health programs with a diversionary program, is up to the task at this point, and so I would ask for a no vote. Thank you.
Thank you for your public comment. This time there are no additional requests.
Thank you very much. That went quicker than I thought. So what I'd like, and there's more than one way to do this, obviously, is just to get a feeling from the members, so sequentially, about major take-homes that they think that we should consider and formulating a motion. I would tell you that Dr. Dengrot, who had to leave, felt that, I'm looking at a copy from his iPad, that a program. He dealt with primarily funding and the location of the program. He was using experience that has to do with what happens in their group in hospitals. He felt that the program, whatever it looks like, should be administered by the medical board and not farmed out to another entity. He felt that some of the funding should include hospitals, insurance carriers, physician groups. He said novelly we should view this as a disability, and the disability carrier should be responsible for some payment, and he would implore the public advocates to help us in whatever we decide to do. That was Dr. Dinger's comment. So funding involving some common entities we know, but maybe we don't think about disability as one of those. And of course, we've always recognized that the public has a certain amount of influence and power, and if we're going to be successful in whatever we do, we're going to need their help, I believe. Dr. Thorpe?
Thank you, Mr. Chair. I have to say I was very compelled by the presentation this morning. It's clear that what we've done in the past was not successful, and what we are doing now is not successful. And I don't think that the language we have before us is really going to take us where we need to be. So I think lots of people have said to vote no on this for obviously different reasons, but this is clearly not the agency that is going to help us. I personally think that the board needs to develop some kind of a task force that develops input from multiple stakeholders, and I don't agree with Dr. I think the medical board I think it should be similar to Washington, where there is an oversight of the medical board, but that the agency is completely separate, that oversees the impaired physician, the PHP, the Physician Health Program. That's my personal sense of what has traditionally been successful. I think it's not just Washington. I mean, of the 50 states, we're one of 3 that doesn't have a program. I mean, that's really embarrassing in a way. But more important than that, it's not just to protect doctors. I mean, the truth is, what we want is doctors that are healthy so they can take care of patients so that we can protect patients. I mean, ideally, we would like to not have to do any. I mean, if we were running a great system in California, we wouldn't have any work to do. But that's not the case. Obviously there are problems. So the best solution is to try to find a program that gives us the most opportunity to intervene in a way that provides healthy doctors so that they can take care of patients in a way that's safe. And that is protecting the public health.
Thank you, Dr. Thorpe. Dr. Sack?
I think I feel the sentiments of Dr. Thorpe and Mr. Watkins. I think, it's not working. The status quo is not working. We need to do something. And whether what that something is, if we vote on this, it's a start. We're doing something. We're not just saying, well, we're just settling for the status quo. And I think that's why I think, although this may not be the perfect system, I think if we start on the path, at least we're working towards something. A task force is great. I think, we need to say, okay, we look at this and we are seriously considering it. We think this is an important issue. By voting it down, what do we have? and I think it's the whole paradigm shift of, oh, you know, we need to take care of doctors. I think it's very important, but the physician, the patient advocates, they go, I want to know if somebody has got a drug abuse problem or whatnot. But you know, as we all know now, drug abuse is considered a mental illness, and there's mental health parity. You know, doctors don't need to disclose to their patients I have hepatitis or whatnot. I think confidentiality is one of those things. You know, patients already want to know if you have a substance abuse disorder. I'm not going to disclose it because then I'm going to think that people are going to sort of see me differently. So I think having it a separate entity from the medical board is something that's a little bit more appropriate than to have us sort of prevent people from self-reporting. And so I think, you know, in my opinion, I think this is a good start. Is this the perfect system? No, but at least we're doing something.
Actually, say good, this is a good start. What are you referring to more specifically?
To having legislation to move forward.
Legislation.
Right, and so I think, you know, that's why I'm sort of in favor of moving forward.
Thank you.
Dr. Hawkins, just if I was unclear, I am not in favor of moving forward. I think that this would be a waste of energy and time. I think that this rule making that we're considering here today, I would vote to not proceed with the rulemaking because I think that it will divert us from actually creating a program that would be effective. That is my concern. If we follow this program, we're going to go down the path. We're going to end up in a program that nobody utilizes because of the fact that there are certain key known best practices that are not included in this program. And that's by creating a task force, the idea would be to find a way to bring people together to understand that the best practices are really, truly best practices in California, in Washington, in Missouri, wherever it is, that's the best way to deal with physician health problems. Thank you.
Thanks for that clarity. Dr. Hauser?
Thank you. I appreciate the excellent presentations today, the robust discussion among board members, and the input from members of the public who are here today. That said, I believe that the proposed regulations are not the best path forward for us, and I agree with Dr. Thorpe that we should withdraw them at this time. I would instead recommend that we request that staff develop a proposal for legislation that would enable creation of a PHP that follows the best practices of the Federation of State Medical Boards. Thank you.
Thank you very much. Ms. Lubiano?
Oh, there we go. Thank you. Listening to the advocates on the call, as well as our experts online, I don't think anyone's happy with what we have now. And so I'm with Dr. Thorpe that I would support not moving forward and trying to get it right with legislation and put in that effort.
Thanks, Dr. Hawkins. I guess I just want to acknowledge and maybe even amplify the comments that were made by the representative of CMA, who was the sponsor of the legislation that resulted then in this rulemaking. And what I think I heard him say, and these are my words, not his precise words, was, well, this was the best we could get at the time, right, through the legislature. Well, that's not good enough, right? And I think that's what we learned from the folks that joined us earlier to talk about best practices. That's what we know from FSMB. That's what we all know from our own experiences hearing from the wide variety of stakeholders we hear from. So withdrawal of a rulemaking that's going to create a program that's not good enough is the right thing to do, in my opinion. The things, excuse me, that I would like to see, I'd like to see us develop a legislative proposal that establishes a state-of-the-art physician health and wellness program and
We've heard from a couple commenters about substance abuse monitoring programs. That would be a small subset, in my opinion, or one program as part of a larger physician health and wellness program. So I want us to think about it holistically, right? And think about this as a mental health solution, a wellness solution, really holistic opportunity. And that's what I think that the folks that joined us earlier today were talking about. This is not just about substance use or abuse. It's about all of the potential things, all of the types of conditions that can lead to that, right? And being preventative and making sure that we catch people before they fall into a situation where they're impaired. I also just want to make the connection, not everyone who has one of these conditions is impaired, right? So we're not authorizing impaired physicians to be practicing. In fact, a program like this, as you heard, would do exactly the opposite. So I'd like us to, one, establish that state-of-the-art PHP. I do want us to have a conversation, a real conversation, and to use the words of one of the physicians who presented, I want us to have a real conversation about us liberating this program from the uniform standards. I don't know if that means an exemption, and there are some exemptions that are already built in. I don't know if it actually the uniform standards, because they say they'll, there's some discretion in their application, whether we use that discretion. I don't know what the right mechanism or avenue is for that, but I do want us to have a conversation about that liberation from the uniform standards in this context. And then my third recommendation would be that we convene that stakeholder meeting, right, TJ, that you were talking about before the fourth quarter of 2024, so that if we're working towards a November date for coming back to the medical board, with a proposal, that meeting has already happened, that we've received that interested parties, so to speak, input. So then we can have something robust to talk about, and we can possibly hit the next cycle, right? So that we don't lose a whole nother legislative cycle. Those are my thoughts.
I totally agree.
Watkins?
Sorry. No, I totally agree with all of with Dr. Taub, Ms. Lawson, everybody that wants the best possible program that we can create. I like the idea of a task force, or even just the stakeholder meeting. I really want to avail myself to that. I feel very passionate about this, and I want to put it in. I think that there's a lot of communication gaps that is taking place because of fear, and I understand all of it. And I think that if we get to speak to all the stakeholders, that we may be able to bridge that. And one of the key things, as Ms. Lawson explained, was if you expand your view, you see that this is a broader issue than just the substance part of it. And the uniform standards, they really focus on the substance stuff, so that's highlighted. But it's actually the greater well-being of doctors to prevent them, as the expert said, from ending up there. And that's something, my personal mission in my own life is the improvement of everybody's mental and physical health. So I feel so strongly about that. And I think this may not be the right course, but I'm as I said earlier, I'm very confident this is the board that can actually pull this off. I don't care what has happened in the past. This is the board. I have seen the brilliance and the amount of cooperation that we have had, and I can say that because I'm kind of a controversial troublemaker. So thank you.
Dr. Yep.
I think my colleague spoke everything I have in my mind already. But I think, one, we have to start somewhere, whether through this or not. PHP have to do, and we want to do it by this board within as much time we have left this year. Stakeholder meeting is important, feedback from all parties important, and I'm not sure this is only the second time back how much communication we have, stakeholder, public member, and also the legislative consultant. Do they hear exactly what we hear today, what our public want, what our physicians want? Like yesterday, 3 questions, same thing. The first most serious substance abuse one, which probably public worry about most. Okay, are we losing those? Are we catching those doctors who may harming the patient? Where there's probably 90% of those physicians who just need stress-related counseling and treatment, like the two programs so today. So I think that work needs to be done, to come to the point how to do the program. But I do think we should have an independent program and partner with the board, just like the two states. And I repeat this morning that I'd like to have in the future, the PHP, that the board will involve doctor from the board, public from the board, and also advocate, get taken from the San Diego School of Public Health, Policy, consumer advocate, so that we want transparency. We want them to know we're doing this for everybody, not just protect doctors. We have doctors, we also want to pay attention to who are the doctors that we need to be disciplined or probation or to take them away from harming patients. At the same time, we also want to have confidentiality that will encourage, and science show that, encourage tribal physicians to come forward to be treated. This is part of my learning from the implicit bias. We don't want to label. It looks like you're depressed, you may need help. As Dr. Sai said, we're not going to ask patients, are you HIV positive? Right? And later the patient will ask, doctor, are you depressed? Are you stressed out? Right? So I think we need to be careful to give room for those doctors who need to be treated or who need counseling. So we do have a lot of work to do, and as TJ say, we can make it work. We need to do more trips to talk to stakeholders, more meetings. I'm happy to spend more time on it. Thank you.
Okay, well, I think so much has been said by colleagues here, but a couple of key points. One, obviously, is what I'll call governance, and then the second being finance. So I, too, would be reluctant to want to go forward without having, starting first with the legislative plan. I also feel strongly about the making sure that we are doing this right, and would be very willing also to participate in working with our board in a broader sense in this very important time. And I would see the board as a convener to bring the collaboration forward that's going to be very important to build this PHP for the state of California, which we heard the state of California is very different, and we all understand that. We're big, we're massive. I think we have to recognize we have regions. We have one state, but we don't have one size fits all in NorCal, Central California, or in Southern California and towards the border. So I would also like to make one comment. I think it's very important, two things, that the chronic disease of addiction is not about people's moral character, and that that pain and suffering, anxiety, depression, we have to look at our culture of how we downshifting by having a couple of martinis or a six-pack of beer is not in anybody's best interest, and that is a bigger cultural shift that we, I think, as a medical community, as a healthcare worker community, have to think about, and really engaging the physicians to be able. I want to make sure that I understood that mandatory reporting, because there is something very interesting that gets hidden in many ways. We try to call it within health systems what is professionalism, and we see someone acting out or not someone responding to emails in a residency program, and immediately it becomes punitive. But it is very hard for doctors, as we learned, to say to what Dr. Yip just said to Dr. Sai, you know what, you look really depressed, I'm really concerned about you. And that goes and speaks back to the larger point of building a PHP program that is addressing the broader issues of all mental health.
Yes, that's it.
Just forgot one point is that just for the public member that we're in the hospital, I actually reached out to USC and Loma Linda to talk to them about their well-being program or physician health program. We've got medical students and residents. We have to start from the beginning most doctors don't get depressed because they're resident. They probably start when they're in college, when they're in taking the MCAT and all that. We have to start to solve the roots of the problem. So this is part of the stakeholder that I think, we include too. And I have an idea that just like the special effective permit, maybe we should have a meeting with all the 9 medical schools together, they achieve what they have been doing for the student and resident, and then maybe we can learn something from them and incorporate into the future PhD program, because they may be the one that refer licensee or future licensee to those PhD. Thank you.
Thank you very much. I think we all heard, and there's a lot of commonality. I'm just going to make a few comments, and then I'll ask Reggie to make a comment if he would. So I heard that many people believe that we should adopt the best practice for PHP in California. That's what the citizens deserve. That will make us feel that we're doing what we're supposed to do. I heard that physician health doesn't just include substance abuse. It's a subset, but it includes a lot of other conditions that are not recognized, but can have an impact on patient safety and optimal patient care. We talked about the collaborative approach that we need to have with a lot of folks, some in this room and some of these lead institutions and not so lead institutions who have skills in this area, and we need to collaborate with them. And the underlying issues I see is public protection aligned with public health, physician health. The sign says this is a chronic condition. The sign says this is a chronic condition. As one of the individuals, I think it was a physician, spoke, I didn't want to be a substance abusing doctor, I'm paraphrasing, but I'm glad that somehow I got to a program that saved me. So, Reggie, comments?
Thank you, Doctor. So just sitting here this morning's presentation and soaking all that in, and Dr. Balad, you don't have to say that twice. California is different. Take it from me from coming from outside California. So, and being, with another state board where we work collaboratively with the PHP program for over 3 decades, and being part of that wellness committee that worked with the PHP. When I first came here, I know we are in a desert here. And so today, this board has an opportunity to pick up the can and don't kick it down the road. So I'm encouraged and also really enthusiastic because I see partnership and handshake, people coming halfway to meet with us, to work with us. So I'm encouraged, and believe me, this gives us, our staff carried today enormous work and bringing the presenters today and working tireless hours behind these regulations, which I keep telling this is a disaster waiting to happen if we go forward. So I'm encouraged to hear the board's unanimous decision to move forward with a fix going forward. And the staff is encouraged, and believe me, we're going to take it and run with it. And I would even put something out there to think about. I know our November board meeting is right around the Thanksgiving holidays, but if we can all work together to maybe set aside that Wednesday for a common work group and the whole board with the proposed legislation, if that's something we can pull together, we can cover a lot of grounds. And we can, have come up with a legislation that may or may not need regulations to go forward with, that will end up with another 4 or 5 years down the road. And then, because you hear the need for it out there, and even a doctor spoke up where he had to go out of state to get help. And also heard from one of the presenters about how this is helping the medical students and the residents. We are making them better before they even come to us for license. So that's important. And then I think it was Dr. Bundy or Dr. Early talked about the funding sources. Again, in Oklahoma, PLICO, Physician Liability Insurance Company, was one of the companies that actually heavily put money behind the PhD program there. So there are good models out there, and I don't have the numbers with me, but
Majority of the programs are separate 501c3 kind of programs, and that helps because I heard a lot of talk about the stigma that physicians have. If it is under the board, there's no separation and there's some mistrust there. So, but we have an opportunity. And again, if California can come up with a program that is with the partnership of the public and the public stakeholders and with their earning their trust for the program, that's something that other states are going to look forward to copy after theirs too. So with that, thank you for the opportunity, Dr. Hawkins.
Thank you very much. So Carrie, is this the time for all that you've heard to make a suggestion how we might approach?
Yeah, I mean, what I'm hearing is that the motion would be to direct staff to withdraw the proposed rulemaking and to work with stakeholders to develop proposed language for a legislative fix.
So moved.
Second.
Have the roll call, please.
Yes. Call my name.
Dr. Bolat.
I was so committed. Excuse me, tell me, what's my name?
Dr. Bolat.
Yes.
Dr. Dingra. Dr. Helzer.
Yes.
Ms. Lawson.
Yes.
Ms. Luciano.
Yes.
Dr. Thorpe.
Yes.
Dr. Tsai.
Yes.
Mr. Watkins.
Yes.
Dr. Yip.
Yes.
Dr. Hawkins.
Yes.
Thank you, members.
Now the work starts.
I just want on the record to commend Kerry put a lot of work in this, and I enjoy reading it and educating myself. I think she deserves a praise.
Yes, thank you. Carrie still has the mic. Okay, moving on to agenda item 14. 13? I'm out of order here, but I do. Page 12. Oh, yes, okay. Moving on to item 13, discussion and possible action on proposed regulations to add the California Code of Regulations regarding fees for petition or penalty relief. Ms. Webb will present this.
Thank you, members. This is, you can find the materials under agenda item 13. And you may recall that at the board's request during its last sunset review, Senate Bill 815 added Business and Professions Code Section 2307.5 to the Medical Practice Act, giving the board the authority to establish a fee for petitions for penalty relief. The process to evaluate and consider each petition currently involves unreimbursed Board, Attorney General's Office, and Office of Administrative Hearings staff time and results in substantial costs to the board. Based on current information and AGO and OAH costs relating to petitions for penalty relief between fiscal years 2021 and 2023, the average cost for board staff time to process a petition for modification or early termination of probation is $1,949. It's $3,738 to process a petition for reinstatement following a revocation or a stipulated surrender. And the total average cost for a petition for penalty relief, either for early termination or for reinstatement, is $19,043 to cover the AGO and OAH expenses. Between 2021 and 2023, the litigation and hearing expenses alone, so not staff time, board staff time, it cost the board more than $1.8 million. those individuals who filed petitions for penalty relief have historically not had to bear any of these costs. Consequently, in light of this new authority, board staff is proposing to add Section 16 California Code of Regulations 1352.3 to set the fees to cover the costs for processing, litigating, and hearing petitions for penalty relief, as well as to amend an existing regulation, Section 16 CCR 1359, to reference the required fee and update the process relating to petitions for penalty relief. The fees would be broken up into 2 stages and would not be refundable. So, for instance, if someone filed a petition for reinstatement of a revoked license, they would have to submit $3,738 to cover the board's average cost to review the petition, conduct the investigation, and prepare the file for referral to the Attorney General's office. If the board then advises the person that the matter is eligible to be referred to the Attorney General's office and set for hearing, the individual would have to submit the payment of $19,043 and have it cleared within 90 days of that notice. This would prevent open cases from lingering on indefinitely. If the members wish to proceed with moving forward with this rulemaking, then I have language for a suggested motion, but I'm going to get your feedback first before I go through that proposal.
I have a question.
Comments from the members?
Yeah, as amended, the amount, dollar amount, is actually in the legislation. It doesn't account 10 years from now if attorneys' fees per hour go up. Are we sort of held to that, or do we need to write something that is a little bit more consistent with price fluctuations and whatnot?
We did contemplate that. It can be difficult to try to quantify what that is. We do have the ability to update the regulations, and if it's just a matter of updating the fee, you know, it's not a complicated reg package. And we can hopefully have indicators that would signal that would help us plan for an increase.
Other members?
I support it. I move staff's recommendation.
Call the roll, please.
Hold on. I want to put the suggested motion into the record.
Thank you.
So I will, the suggested motion, and then someone can just say so moved and second if you agree with this. So the language for the suggested motion would be to approve the text, direct staff to prepare the necessary regulatory documents to submit to the Department of Consumer Affairs and the Business Consumer Services and Housing Agency. Upon DCA and agency approval, direct staff to submit the documents to the Office of Administrative Law to notice the proposed regulatory language to add Section 1352.3 and amend Section 1359 of Title 16 of the California Code of Regulations, and if no substantive adverse comments are received during the 45-day comment period, direct staff to finalize the rulemaking file and submit it to Department of Consumer Affairs, and upon approval to the Office of Administrative Law, and to make any technical or non-substantive changes and adopt the text as noticed without returning to the board.
Second.
Any comments from the public in the hearing room? Comments from the public in the hearing room?
My name is Lucas Evanson, and I'm speaking on behalf of the California Medical Association. CMA has concerns with the cost of over $20,000 to petition for early termination of probation and over $22,000 fee to petition to reinstate a license. Setting a fee this high will discourage nearly all physicians from taking advantage of the process that's authorized under the law. There is a middle ground between paying no fee and paying all the costs. If a physician is able to successfully improve themselves or their practice, they should be encouraged to return to practice. This proposal would also include physicians who have been put on probation or surrendered their license due to impairment as a result of a health condition. We just had a conversation about the lack of resources physicians have to address these conditions, which may impair their practice in California. Yet the board is now proposing to further bury physicians in more barriers to recovery or self-improvement. We ask the board not adopt a fee this high. Thank you.
Are there other individuals in the room? WebEx?
Oh, hold on.
Oh, okay. Please come forward.
Forgive my ignorance on this, but are people actually paying $20,000 in order to get a job? Because that's what it sounds like as it's being read. What are these fees for? Why are they? Just can you might answer what the fee consists of? Because under most circumstances, you don't spend money to get a job. So what is this fee about?
I think if you refer to the board meeting materials for the section 13, for item 13, you'll see a breakdown of the costs. And it's to, the board has to do work to process these petitions. And right now it's unfunded by the people who are seeking the change in their circumstance.
Wow.
So,
well, I'll look back through that. It's just that it just seems so inane to be spending this much money in order to go get a job if you've already been to college. That's all I'm saying. Anyway, but bless everybody.
WebEx?
Oh,
oh.
If anyone wishing to make a public comment, the Q&A window and the hand raising feature available. I'll give you a few seconds to queue up. Last time I spoke too early, so I'll give everyone a few more seconds. Not seeing any questions. Dr. Hawkins.
Thank you. So now I think you're ready to do the roll call vote.
Excuse me, Mr. I don't think you asked for, did you ask for comments from the members? Well, I guess I just was totally oblivious.
Right. You want to say
something?
something?
Another world, in another universe, I guess.
Well, we're among friends.
Well, I recognize that there are costs associated with the work that's being done, and I don't think that should be ignored, and I think that should be shared by the applicants. These costs are really significant. I mean, $20,000 or $23,000 or whatever it is, it's a fair amount. It's actually quite a bit of money, and it does seem to me that I don't know how to do this without, I mean, is $10,000 enough, or, you know, I don't know. I guess this is the best way to do it, but it is going to be a significant dampening effect on, and maybe that's the desired effect, to significant dampening to people requesting their probation to be abbreviated or to be reinstated for a license. And so that's my, it does seem pretty heavy fine to me.
Thank you. Please call the roll call vote.
Dr. Bullock?
Yes.
Dr. Helzer?
Yes.
Ms. Jones? Sorry. Ms. Lawson?
Yes.
Ms. Lubiano?
Yes.
Dr. Thorpe?
No.
Dr. Tsai?
Yes.
Mr. Watkins?
Yes.
Dr. Yip?
Yes.
Dr. Hawkins?
Yes. Moving to agenda item 14, update and discussion on the Midwifery Advisory Council. Ms. Wisner.
I am. Hi, everybody. I'm Madeline Weisner. I am the chair of the Midwifery Advisory Council. I'm also a California licensed midwife. And I'm pleased to provide you with an update on the MAC. There are no new agenda items being requested for the May 2024 MAC meeting, as all of our agenda items have been previously approved by the board. Thank you. The last MAC meeting was held on February 15th, 2024. At this meeting, the following actions were taken, and the MAC was provided with the following information. We approved meeting minutes from the March 30, 2023 MAC meeting. Attendees received an update from the MAC chair, discussed the goals for the MAC, received an update on current midwifery legislation, received an update from the task force on Medi-Cal related issues, received an update on the midwifery program and the licensed midwife annual report. We voted on the appointment of new officers on the MAC, discussed birth certificate and social security registration issues, discussed midwife access to screening equipment, including newborn hearing screening equipment for newborns. And we voted on future 2024 MAC meeting dates. And that's all. Thank you. This concludes my MAC update for the day.
Thank you very much, Ms. Wisner. Moving
Ms.
to...
Weisner.
Thank you, Ms. Weisner. Moving to agenda item 15, election of board president and other vacant board offices. The only vacant office will be the president's office. As you're aware, I'll be departed with mixed feelings. At this point, I'd like to nominate Ms. Christina Lawson for the presidency, and I hope she will accept it. The medical board has substantial uncertainty and vulnerabilities going forward, and I believe we need leadership from the individual with the most experience and tested skills, and I believe that's Christina.
Good.
Are there other nominations for president? Then we can call the roll call vote. Thank you for that. Comment from those in the room. Comments from those on WebEx?
The hand raising feature in the Q&A window open. Anyone wishing to make a public comment, please queue up. We have a few more seconds here. Not seeing any requests, Dr. Hawkins.
Thank you, Mr. Struthers. Could you please call the roll call vote?
Dr. Balot?
Yes.
Dr. Helzer?
Yes.
Ms. Lawson?
Yes.
Ms. Lubiano?
Yes.
Dr. Thorpe?
Yes.
Dr. Tsai?
Yes.
Mr. Watkins?
Yes.
Dr. Yip?
Yes.
Dr. Hawkins?
Yes. Congratulations again. And we know that leadership requires support from all the members and the public, and particularly the staff.
I'm sorry, we need to go back to public comment on the midwifery update.
Oh, sorry. We're going to have to do this again.
No.
Okay. I'm really not rushing. I got all these arrows saying, do this, do this, do this. So after the update and discussion with the Midwifery Advisory Council, are there comments or questions for, I guess comments now for members in the room? Comments for, the board, comments from members in the room? Comments from those on WebEx?
The hand raising feature in the Q&A window open. Anyone wishing to make a comment on the midwife update? Oh, Ms. Weisner has her hands up. Let me see. Should be receiving a prompt there, Ms. Weisner.
Hi, Madeline Weisner again. Oh, wow, I'm not going in there. I just wanted to give everyone an update that Medi-Cal has added codes that are billable for licensed midwives. And what this means is that midwives are closer to being able to actually bill for the crucial maternity care services that we provide to California Medi-Cal beneficiaries. Licensed midwives have been a covered benefit with Medi-Cal since 2015, and we have been struggling for nearly a decade because of our regulatory oversight and because of general misinformation about licensed midwife care. We've been struggling to get this benefit truly executed for Medi-Cal members. And so this is a really fantastic update that hopefully will broaden access to this service and lessen the incredible burden of maternity, our maternity care crisis in California. So it's a piece of good news.
Sorry about that, Dr. Hawkins. Thank you, Ms. Weisner. That's all the requests I saw.
Moving on to agenda item 16. Yep.
Can I go back to agenda item 15? I want to thank you for the leadership, friendship, guidance as a board member friends, and you build trust among the board members and the public. I strongly recommend you come back to us.
And Dr. Hawkins,
it's been an honor and a pleasure.
Dr. Hawkins, since you are so generous in allowing these last-minute requests here, and Dr. Yip took advantage of it, can I make a couple of statements? Thank you. Yeah. Dr. Hawkins, on behalf of the MBC family, I want to express our sincere gratitude for your service. Serving the board is the toughest volunteer job that you had, and the staff wants to recognize that you took on your board duties with dedication, grace, and seriousness, and thank you for your service, sir. And with that, also, we want to give you something. This is a little plaque, President's Service Award, in honor and recognition of the great and distinguished service provided by Dr. Randy W. Hawkins, MD, to the consumers of California as a member of the Medical Board of California from 2015 to 2024, including his years as Vice President and President.
Thank you. Thank you very much. That will be displayed prominently in my office. Great. Beautiful colors, too. Oh, I'll get you later. Thank you. Thank you. Moving to agenda item, I'm sorry.
I'm going to follow with with Dr. Yip, and just again to shout out to you for just tremendous public service, but also I know how much you work with our medical students, residents, and fellows, and that is really, really hard work. And, the intergenerational wisdom that you impart on them is really, really, really critical. So I know you will continue in that work, but like others, I hope that you will be back in some manner with the board. And I'd also like to just take 30 seconds and really acknowledge our other members here that are more serving in the executive position. Dr. Helzer is our new secretary, and to Ms. Laurie Lubiano, who, has been really working a lot behind the scenes, and I know that this this trio will really do some great work together. And as a member, it is really great to see the continuity and the strength that we'll have with our new executive leadership. So thanks, everybody.
Michelle, thanks for all that, for all of it. Any other comments? Okay, great. Moving to agenda item 16, future agenda items. Do any members have suggestions for future agenda items? And Reg, do you have a follow-up on the artificial intelligence that we've tried to arrange the last couple of months?
Yeah, our first lead is non-responsive, so we are looking at other presenters.
Yes, other members for future agenda items?
Yeah, I just want to follow up on that AI, and I'm just wondering if there can be somebody that's actually, and you may have already done that, to ask, that's actually piloting the AI, because I think it's so important, and they really are in the trenches right now, and be it San Diego, UCLA, I don't, whomever, thanks.
Awesome.
Yeah, I'm not sure exactly how to frame this future agenda item request, but an issue that continues to come up in our panel meetings is the idea of coordination amongst various state agencies who have oversight over whether it's hospital systems or nurses or physicians, right? And we had a case that we evaluated this week where that was at issue. And I wonder if there's some way we can have a conversation, I guess, about the responsibility across state agencies, where that responsibility lives, how we can better coordinate, because I'm learning that the coordination may be lacking, so to speak. So I don't know exactly how we get at that topic, but I think it's a topic worth us all talking about and thinking about what solutions are over time.
Other members? Dr. Palat?
I wanted to ask for clarification, because I too I may be thinking something slightly different, but it has always come to my attention that through this coordination, be it a managed care plan, be it government or non-government, be it the hospital system, be it the IPA, MSO, whatever all the alphabet soup is, there's pieces within the healthcare delivery that also, I think there's accountability. Are you talking about that? I just wanted to try to understand.
I think that's broader than I was envisioning, right? I was thinking about having that conversation specific to California state government, right? And where various responsibility or accountability lies. That doesn't mean that's not important, right? That we also think about that level of coordination as well. But what I was talking about specifically was coordination amongst state agencies, and that's just been brought to light. There was a very there's been a newsworthy matter in the community where I live that our staff's aware of, where that coordination has been something that's been concerning to me and that we've talked about, and I believe that's under investigation. So I don't want to say anything further about that. But then we had this case come up in our panel this week where it really wasn't about finger pointing, but it was unclear who had responsibility or where the accountability really lied. And again, that's because there are multiple agencies regulating their own individual components of this system. And the idea would be to understand that first, and then think about how we might better collaborate and coordinate.
Dr. Hauser?
I have two requests. The first will be an update from Mr. Varghese on the impact of cost recovery on the board's fund condition, as well as our experience with collections, and in addition, a timeline for the board's plans to pay off loans that we've taken over the past couple of years. My second request is that we adopt a 2025 meeting schedule at our next meeting. Thank you.
Great. Dr. Thorpe?
This is similar to what Ms. Lawson had brought up, but I think there's two issues. One of them is the fragmentation of healthcare that has occurred as a result of the fragmentation of the healthcare delivery system. We're facing we're facing a catastrophe across the country, I believe. And that fragmentation occurs at all kinds of levels. It occurs within the medical group, it occurs within the health plan, it occurs within the managed service organization, the independent practice associations, the major financing agencies of healthcare, both the private financing companies or healthcare companies and the state and federal healthcare companies. It is the problem is, it used to be that the physician was responsible for the patient all the way through. You took care of them in the hospital, you took care of them in the nursing home, you took care of them when they got out of the hospital, you knew what happened in the hospital, you knew what happened at every step of the way. You probably even assisted in surgery when they had their whatever else done. That is totally gone. And that everybody operates in their own silo. Everybody says, well, this is my job. I don't go outside of my job. I'm not taking care of that. That's not my job. And there's no one who is the shepherd anymore that takes care of that process. And that is a catastrophe. That will become a catastrophe. So that's just a little, I mean, that's really the much bigger picture than what Ms. Lawson pointed out. And I don't know how to address it, how to fix it, but we're not the only ones facing it. And I think somebody needs to say it out loud. So that's one thing, is it's fragmentation of healthcare. Second thing is something I've asked for several times and has never happened to my knowledge. And maybe it happened when I was gone. I've only missed a couple of meetings, but there's a problem with opioid prescribing in that the pharmacies have become more and more restricted in the number of pills that they can actually acquire for distribution per month or whatever it is. It has come to the point that there are people who can't get medications that they are legitimately required or legitimately have they legitimately have a right to. They're prescribed appropriately, they're on a monitoring program, all the things that need to be done, but they can't get their meds because the pharmacy doesn't have enough pills. There's another issue about attitude with the pharmacies and their denigration of patients who are on chronic opioid therapy. That whole issue, I think, is having a conversation with the Board of Pharmacy, or at least someone from the Board of Pharmacy, to actually review this problem with us and help us to come to a coordinated solution of it. Given the new opioid guidelines, given, we've still got a lot of work to do there, talk about fragmentation of care. We've got all the different agencies that needs to be dealt with, but pharmacy is one place to start. So I ask for the Board of Pharmacy to come talk to us.
Well, so as a physician in private practice who does prescribe opiates and benzodiazepines for individuals who qualify and stick to my plan of contracts, one pharmacy, monthly evaluation only after the medical workup, we do run into problems. We run into problems where the pharmacist says, well, I'm not going to dispense this medication. And they say, well, I'm not going to do it because the insurance company says X, Y, Z. Exactly. And these people deserve it. That's why they're in the program that I have, and they receive the medication. There was comments at the Federal State Medical Board meeting speaking about medical directors denying care, which is another part of what's going on. Yeah. And so it's a good topic. I don't know how we frame it precisely, but these are important topics. Other individuals, board members?
Yeah, maybe we can have a presentation in the future. I was at a legal medicine conference, and a presenter was giving a talk about Beta Heart. They're a member of the Hospital Quality Institute, and it's a different way of looking at adverse events. HEART stands for healing, empathy, accountability, resolution, and trust. And the way they look at when something unintended happens, they bring all the participants, the patient family, the doctors, the nurses, all together to talk about what happens. And of course, in hopes of addressing people's concern and preventing future harm. And I think that sort of communication early on is extremely important, because I think a lot of times when adverse events happen, patients, their families have no idea what happened, what's going on. And then, of course, on the healthcare side, doctors, nurses go, okay, we don't know what we can say, what we can't say. Let me call risk management first. And so I think looking at it, I realized that over 40 hospitals in California are also our members, including Alameda Health System, the John Muir Health System, USC, City of Hope. And I think, you know, if all over 40 hospitals in California are participating in it, is it time we look at something to sort of change our approach to how we communicate with patients and prevent harm in the future. So something to look into.
Beta like alpha, beta, and then HIRT?
HEAR.
Okay, great. Thank you.
That's for referral to staff. Is it possible, and I don't know what other board members feel, but given this substance use disorder issue that's going to continue to be of concern, and is concern, do we have data and information on our other healing arts? And I think it would be interesting to be able to say it's, you know, it's doctors, nurses, pharmacists, podiatrists. I think that's really important because it contributes to the challenges on top of challenges in the healthcare workspace.
Other members? Comments from those in the room? Yes, come forward, please.
Thank you for allowing us to comment outside of going to the website to try to add to the agenda, because that doesn't seem to ever work. Now, the other thing is we have two things that some of us have been talking about, and we are looking for a review of the proper standards. For example, it shouldn't be acceptable for all bones to be broken in a person's chest, plus the manubrium torn away from the sternum to do CPR while people are practicing CPR on a person. And that has been taking place, and we find that in autopsies. Even if the person had lived, well, then they would be in really bad shape. Okay, so we want to see something about some changes to the proper standards all the way to the American Medical Association. And then also we are requesting open access to reports generated because of complaints made by members of the public, because the situation is presented, but the public is left in a sort of benign situation. Well, it didn't come up to the bar, you know, it's like, so what was the bar? So what happened, you know? So we're asking for you to please give us a chance to find out what actually happened. Someone just mentioned that the public is left wondering what's going on. But we are told that we cannot have access to the reports after a complaint is made. It's like, oh, well, it wasn't bad enough. Well, what happened? So that's the prayer that we have with that. And we substantially appreciate you and hope that all of us can get better, because particularly, like, for instance, I've talked to so many veterans, and they're like, don't go anywhere near the VA. Okay, so then we need to have committees that determine why people are shunning certain services because they're afraid of going there for help, because they feel like they'll be hurt when they go there. And there are even such rules as over there where if you are there for 14 days, but then they can decide that you are a mental case and you have to have a court order to get out. You know, it's all kinds of strange things going on that are called standards. So the standards actually need to be looked at. So could we have a review of the standards? And also, may we please have the opportunity to actually see what the report said, even if names are redacted. Just let us know what happened. We just appreciate that. And thank you for your time and services, all of you, because I know coming to the meeting is a headache. Being outside the meeting, I'm sure, is a headache, So, oh, and by the way, it's a little lemon water back there. Somebody wants some. I brought some in because I was tired of sitting here being thirsty. You guys be blessed.
Okay, thank you. WebEx?
The hand raising feature in the Q&A window open. Anyone who wishes to make a public comment, please queue up now. First request we have is from Monty Goddard. Should be receiving that request on your end.
Good afternoon. I sat through this whole 8.5 meeting. I take my hats off to you guys and gals. You're quite an incredible group. My point is I want to strongly endorse the recommendation by Dr. Thorpe that you schedule an agenda item pertaining to the shortages of opioid medications on pharmacy shelves. I can tell you, I'm a witness to what he said. What he said is absolutely true. People with legitimate prescriptions are going to pharmacies and being turned down, not because there's a question with the prescription, because if there is no medication. And I've spent the last 6 months researching this with colleagues of mine. I've published a couple articles. There's two things that are going on with the shortages, separate from the generic medication and low cost or low financial rewards to the manufacturers in that. The two main drivers are the DEA production cuts every year. And the more recent one that really is what's causing what we're seeing on pharmacy shelves today is the nationwide settlement with the state attorney generals and the 3 major distributors of opioid medications of all controlled substances. It's having a severe impact. On April 11th, I listened to a briefing by the National, what do they call themselves? The National Association of Pharmacy Boards, or Board of Pharmacy, about medication shortages. There was no mention in that brief to the pharmacy board of this issue. It's a serious one, and it needs to be brought out into the light of day. Thank you once again, Dr. Thorpe, for sticking up for innocent pain patients. Thank you.
Thank you, Monty. At this time, Dr. Hawkins, I don't see any additional questions.
Thank you very much.
Dr. Hawkins, just one other item related to this problem. We saw in one of our items of business, I don't think we discussed it actually because it wasn't being acted on, but there's an increase in the number of overdose deaths in spite of the dramatic decrease in opioid prescribing by physicians. Somehow people are making the assumption that the problem has not gotten better because doctors are not doing their job. But the problem is not that doctors and medical boards and whomever are not doing the job. The problem is the amount of fentanyl that's being, and I don't know that we have, and I'd like to see data on that. And I don't know if there is, I'm sure there's got to be data on it, but I think that misconception needs to be addressed.
Well, thanks for deciding to bring that up as well. I guess we've finished with WebEx. Any final comments from any of the members related to future agenda items? Okay. Well, our next agenda item is 17, closed session to conduct the annual evaluation of the executive director. And it looks like time has worked out pretty well for us. I don't know where that is, though. It was taking place.
Yeah, you stay here, and we should have a representative from DCA who will be joining, and everyone else will exit the room.
Right. Well,
and for the online attendees, just so you're aware, the meeting we will be displaying a closed session. Screen
screen here while we're in it. There won't be any audio or video. We'll return to adjourn, and that'll be the end of the day. So you're welcome to stay, but there's really no further business. Thank you all for attending.
We're out of closed session, and the last agenda item is adjournment. Safe travels.